path that he should be in. And what I've always in my profession sort of had the vision around of, how do we do something that's in between there? How are we helping people understand what's possible and then leading them down those paths? And oftentimes, unintentionally, as professionals, we lead people down a path because we're like, oh, you're 18, you should go get Social Security. Now, are we really thinking about the implications of that? Are we really thinking about the fact that you're going to tell me to go get Social Security, but you're also telling me I should be employed? Like, so we don't think about the implications of some of us just sending people to resources and services without helping them make those informed decisions about those pathways. So one of the things that we've been doing in Minnesota through our work is actually building life course pathways onto that website. And I recently had a conversation to them that said, you know what? Why don't we have this in Missouri? I'm in Missouri. I really think that this needs to be in Missouri. And have spent a lot of time over the last 2 or 3 months trying to understand, what did it take to do this? How is it different than, let's say, the Governor Council on Disabilities, directory? It's not a service directory. It's not intended to be a service directory. It's really intended for people to help have informed based options counseling, to help people sort of map things out. The website itself almost serves as that guideline for the staff that then are doing that. So whether they're family navigators employed by Disability Minnesota or not, it doesn't matter. Everybody can utilize those pathways and some of the resources on there. So this is just one of the examples that we're working around across the country, but it's a missing piece, right? Because how many times, I can't tell you how many times I've talked to a family who's now become a family leader because they don't want somebody else to go through what they went through. And their first thing is we need a directory. Well, we don't need more directories, guys. They're outdated the second you get one done, right? And what we also don't need is for 150 of us to be creating directories and resources, because none of us has the time or the money to keep them up and know the best practices. And so how can we really leverage the expertise of everybody you have in the autism profession, but have it in a way that it's going through some sort of clearinghouse? And that's what they really are working to do. And it's a really neat relationship, and it's some cool stuff. Okay, for some reason now, can you take that mouse down to that little arrow, because it's not letting me do. Yeah, just down on the left-hand side, and then I should be okay. Yeah, just click right there. Yep. Okay. All right, so I'm gonna just kind of breathe and pause for a second, but I'm going to also tell you about some other things that are happening in the state. So October 1st, Missouri was awarded what's called the No Wrong Door Governance Grant. Why does that matter to you? Why is that important to you? The federal government, the Administration for Community Living, they say since 2003 have been setting the stepping stones for this conversation through a number of the initiatives that they've worked on. Back then, the Administration for Community Living was very siloed within themselves of the aging community and the DD community. Fast forward 20 years, you see them now really working in conjunction with one another. Why does this matter to autism? Why does this matter to developmental disabilities? Well, because they're working very closely with the Center for Medicaid Services and the other federal agencies to say, we recognize there are gaps to people getting into services and supports. We know that our systems are not efficient. We know that they're all very different. And so over the years, there was some funding out there for states to start working on No Wrong Doors or aging and disability resource centers. The DD community was always either left out or an afterthought. That's changing at the federal level, but what the federal level is also doing is recognizing that there are some key elements to how we can make our systems, our front door of systems, be more efficient and be more effective. So recently, they released an RFP that was really focused on developing a governance structure inside a state department level, saying you've got to change your front doors. They need to be more customer friendly. They need to be more person centered. And we know you enter doors in a lot of different ways. This is driven predominantly in states from the aging perspective, because obviously we're dealing with a lot of the aging population, and all of us will go into that population at some point, in the independent living center movement. We were awarded that, being a USED, so we will not leave out the DD community in this conversation, and the autism conversation. But what we know and what's unique about us, when you're looking at long-term services and supports for someone that's aging, you're looking at somebody that's probably going to interface with that for 7 to 15 years, right? We know that the people we're talking about, this could be the day they're born. This could be the day they got a diagnosis at 13 or at 3. So we're talking a whole different, what happens not just in a 7-year period of long-term services and supports, but we're looking at that long-term sort of door. So your door might be your doctor, your pediatrician, your door might be your school. But the other question I always have and bring up in this conversation is a door to what? So when these were originally developed, they were doors to the Medicaid waiver doors. But what we know is there's other doors. There's doors to employment. There's doors to, inclusive education, that are the stepping stones that you may or may not ever interface with the state service system. You might need those services, but you might be on a wait list. So what are we doing in the meantime? What are the other doors that we're accessing? So I bring this up because it's brand new. If you've ever gotten a grant or a new initiative, we're like 2-3 weeks into this. But one of the things that we're working on, and one of the things that we're charged with, is developing a governance structure across the state key departments that interface with anybody. So it's behavioral health, it's DD, it's aging, special health care need, veterans, and so when they start looking at populations that need long-term services and supports, it's very broad from the federal perspective. We are charged with, in the next 2 years, to develop a roadmap and a plan on exactly how those governance leaders within those key departments are responding at a department level, and at a future level. And so it's looking at the cost, it's looking at different things around training, and it's even looking at things around interoperability of our systems. So, these aren't new conversations, they're conversations that are already happening across our state and in our departments. So it's not a new initiative, but it's to tie those initiatives together. So for example, there's a big initiative around how are we working with the ER systems, with homelessness, and the Medicaid data, right? And how does someone not have to tell their story 12 times to get 12 different services? So this is a brand new opportunity that I think is important that this commission's aware of, because how can we make sure the autism community's voice is in that conversation? The first year is really, we are partnering with Alvarez and Marcel, which works a lot on that sort of policy leverages, and doing mapping, both at a process level, journey mapping with the different populations. We'll be doing key informant interviews. And so how are we spending the first year really gathering the information that we need, so that next year we can co-develop with all of you guys and other stakeholders the recommendations that can then lead the state in all of their work related to that. So some of the key partners that we work with is Medicaid agency, the State Unit on Aging, obviously the Division of DD, Behavioral Health. A lot of states don't have voc rehab at the table. They are right there front and center with us at the table, because we see them as an integral part of the long-term service conversation. We see housing as a really long-term part of this conversation. So we're adding different partners to that conversation. We're driven by some key structures that other states have as key elements in there. And I only put this up here because I saw through some of the work that you guys were doing, you were talking about the sort of eligibility issues. And the eligibility for education is different than the eligibility for state DD services, and that's even different than the eligibility for Medicaid waiver services, right? And so you see down on the bottom, streamlining eligibility for public programs is a major focus. Not only in streamlining the actual eligibility, the fields, the data, the forms, but are there ways that interoperability of these large data sets can talk to one another with information exchanges? The other thing that I thought I'd point out there is that public outreach and coordination of key referrals. So when we start talking about the informational needs, that options counseling, we're going to do a really deep dive into the workforce that we call information specialists, not just case managers. It can't fall on a case manager that's gatekeeping state service dollars. It's got to fall on what are some of the other positions. We know hospitals have care coordinators. There's all these other sort of workforce in the middle there that doesn't see themselves as one united workforce, but how do we really look at that workforce and make sure they have the skills that they need? So I gave you a lot of information, only scratching the surface on this stuff. I hope that I hit what you wanted me to hit. John challenged me and said, well, if you could like come up with some concrete recommendations, what would you do with all of these? Behind there, I have lots of strategies related to these recommendations because the reality is there's a lot of really good people in the state of Missouri working in these areas. So how do we actually leverage and connect those really good innovations happening? And so, if I could have a dream, is that there would be in every county, I don't care where they're housed, but every county there would be a peer specialist or a family peer specialist working with families, right? Maybe they're housed at a county board. Maybe they're in the autism center. Maybe they're in the school. Maybe it's a freestanding family organization. Maybe it's, I don't care where they're at. Families just need them. They need them really bad. I think that the other thing that I could recommend and that I'm seeing across the country as well as here is that everybody says that those positions would be really valuable to have. No one wants to pay for them. They're the first to go from every provider organization that decides to put one in place. Training for families and self-advocates is always the first to go to when we're cutting budgets. So how do we flip that and prioritize that investment and recognizing how to do that? But how do we also train that workforce so that they are actually moving people in the direction that they want to go? If you have a family navigator that's pushing for everything that goes against the system or what the system's trying to do, then that's not good either. So how do we really see that as a workforce and not just like, oh, that's a volunteer mom. Isn't that nice? She's working with those other moms, but see that as a valuable part of our interdisciplinary teams. The other thing, I really think having some sort of, disability planning hub in the state of Missouri. There's a lot of really, really great resources out there. They're either great at a local level or a regional level, but how are we scaling that up? Because we know not everybody can know everything about how to help somebody navigate. A medical professional can't know everything about our state service systems and vice versa. So how are we giving people the tools to get to people that know that stuff? I'm not sure yet, but somehow we've got to make this front and center in the No Wrong Door governance grant. And so I'm keeping that kind of in mind. I don't know the answer to or the strategy to this, but when we first were talking about transition age, there really are strong state policies and federal policies regarding to, starting at 12, 14, 16. That's not happening in our schools. So the stuff is there. How do we help make it happen in our state? And how do we enforce it? Or how are we giving the schools or the providers who need to do it the tools to do it? So those would be just really high level recommendations off the cuff to seeing and meeting some of the needs I've identified. But I know that these are other things that you guys have identified as well. So that is what I have for you.
Thank you. An overwhelming amount of information, but extraordinarily useful, I think. So with access to the slides, we can all spend more time. Because we've had a couple of conversations over recent weeks, I've done some independent research into the work that you guys have been doing for over a decade. And it has really changed my thinking. So I think using this information really offers us an opportunity to think about the same issues that we've been talking about, but to think about it in perhaps a broader and more systems approach fashion. And I think this is my own personal opinion, and I'm going to open it up for obviously questions and discussions in a second. But my opinion is that when a commission is asked to perform a function or an analysis, one of the key groups of stakeholders are going to be systems operators within the state, within the schools, within healthcare, et cetera. And so I think this approach and the groundwork that's been done could be really extraordinarily helpful, I think, for us. But so I'm going to open up for questions or discussion. We've got 20 or 25 minutes just kind of open right now. So please jump in and ask Shelley anything you would like or share your thoughts.
I have a question. Just kind of following up on what you mentioned towards the end, where you're talking about the family navigators and support coordinators are always the first to go. You know, how do we justify maintaining the spending? You know, it sounds like you've done a lot of work in various states, and you've seen the implementation of, you know, these really effective life course pathways, which is great. I love that concept. I'm wondering if you're aware of any economic data that might suggest that there is some sort of a societal economic gain by getting people on an effective pathway early, to where it increases the odds by X percentage that they're going to gain, you know, meaningful employment, and then parents will be able to work X amount more percentage of the caregivers and so on and so forth. Are you aware of any data out there that could be used to advocate for things on the state policy level?
So a number of years ago, DMH commissioned the Institute to do an economic impact study on the Partnership for Hope waiver. So it's a study that looked at not only the impact on the individual, the family, and the county, and the state, I think. I bring that up because that's where I'm hearing across the country people need to go in terms of these conversations, right? Because the economic opportunity of a family not working anymore has a big impact too, right? But also then employing some of these new positions and these new ideas. And so there needs to be more of those. But there was a small scale study on Partnership for Hope. You know, specific to the question around, you know, it's interesting. There's tons of research everywhere that says, even look at cancer research. You're having a peer group or talking to somebody with cancer. We know it's valuable, right? But how do you make it actually a billable code? How do you get professionals to actually see that peer support specialist as an integral part of that interdisciplinary team, right? Some of it's attitude, like, oh, they're not trained, or they don't know, or, So there's a lot of different things that I think are happening. It's a matter of lining all of those up and turning some of those, into some meaningful impact. We were talking yesterday that, there's a federal email going around really pushing, I won't say it the right way, those codes we were talking about yesterday. And you could fill in the gaps of me using my layman's term of explaining it. But there are different initiatives trying to gather the information to enforce that, right? I had a conversation yesterday with somebody on the systems of care side that said, written into some of the contracts for some of the behavioral health entities, they're required to have peer specialists and family peer specialists. So some of it can even be contractual. And that wasn't your question, but those are some of the levers that can be put in place to support it.
Dale, did you have a question or a comment?
Yes, my name's Dale Stone. I have a comment and then a question. You mentioned, Shelley, the importance of navigators, and we're the parent of a young man who's 40, was not diagnosed till 30 with autism, and our support coordinator through SB 40 is an answer to prayer. I mean, she just knows and helps us in so many ways. So I just want to support that from a parental voice. And then my question is, you talked about working with school districts, and how how much success or have you worked with rural school districts? I've spent all my life in small counties. How do rural communities receive and respond to uh, ideas and help?
Well, so, I have the fortune of working with people that want to work with me, right? Because we work on the demonstration side of things and we bring ideas to people. And a lot of these ideas right now, because are because a teacher or a parent have found out about life course and they've taken it and advocated it and spread it in their local schools. There are places all over. I mean, we don't have a study or a map of where it's gone because people just come to us and come to our workshops and then take it back out again. But I will tell you that there is a lot of buy-in for it because a teacher can use it and they can implement it totally different in the classroom, but then the person running the IEP can use it totally different. And then families are using it for family workshops or transition plans. And so there's buy-in usually because it's whoever brings the seed of the idea there and allows it to spread. There are some rural schools that have contacted us, but it's not at a school level implementation, if that makes sense. It's sort of starting almost grassroots up.
Thank you. Thank you.
Yes.
This is Carrie. I just want to say thanks, first of all, for coming and presenting all of this information and sharing with us what you guys have been working on. And by either happy accident or because it's the right path, you'll see a lot of the stuff that you've mentioned in here were things that we have also brought forward as what we were thinking would be some of our recommendations for transition. Maybe not quite as in depth because you've been going through that a lot more than we have, but this themes are very much the same as far as what we were leaning towards from our work group.
Other thoughts or questions? Yeah, I mean, my sense, very similar to yours, Carrie, is that this is certainly more comprehensive and more in-depth, but it is pretty much right on point in terms of the sorts of issues that we've been circling, if not necessarily solving quickly. But I think we've had our own learning curve over the last 9 or 10 months, I think. So I certainly say I have had.
I just love the presentation. Thank you. As we transition from this year to next on another topic, this feels very much like a nice organizing way to think about how we make those, our next conversation with different age groups, et cetera, because it's really a lifespan type of approach, which I really appreciate.
And I did offer that to John, that I'm more than happy to stay engaged however you want and help you think through, because I think your next one is the adult services.
Early childhood.
Oh, early childhood. Okay, well, it doesn't matter which life stage it is. If you have the same framework to look at those different life stages, because your recommendations, for example, of a family navigator or peer specialist aren't going to change, right? So some of them are really life stage specific because of the services or the policies that you're accessing, but then there's continually across the lifespan.
I'd add also, and I think it's probably in all work groups, is that so much of the transition conversation as well. If you wait till the transition age, it's too late. You need to be starting earlier. So it is very much tied together.
Can you all hear the conversation in the room? Good. Okay.
Yeah.
Okay, great. So Shelley, I have a question, and it reflects my own limited experience as a healthcare provider in a community which is relatively affluent, St. Louis County, West St. Louis County certainly, although we serve children from all over the region. About 40% of the children that we care for in our center or provide therapy for or CMS covered in terms of their health care. So 60% are not. And so my question for you is, have these issues gained any traction within healthcare financing organizations, with insurance providers, large HMOs, et cetera.
Yeah, actually, it has. We've been having conversations with Blue Cross Blue Shield, with Optum, a number of the big sort of. I feel like there's really only 2 or 3, and they all just have a bunch of different names, no matter what state you go into. For a couple different reasons. One is you're seeing, a lot of those managed care organizations kept pretty separate the public sector and the private sector of their systems. But what they're starting to recognize is that some of the requirements for the public sector side are actually things that are beneficial on the private sector side. In Arkansas, or excuse me, I think in Arizona, for example, just if you get insurance from that MCO, it's just part of your benefit package that you have a navigator you can call, especially if you have someone with complex, they call them specialty populations, right? And so they've built in some of those navigational components. Some of them have worked on different sort of websites. But you're starting to see in the sort of employee world, businesses are starting to recognize that a number of their staff are caregivers, right? Especially caregivers of children with autism, and it's making an impact on their bottom lines. And so you're seeing employee benefits. Big corporations start talking about having some even in-house at their businesses. And I always tell people that I think it's a really interesting conversation, because if you are a family that has engaged with government resources, in some ways you have more access to information. It sounds kind of weird, than families that don't and they're engaging with their private insurance companies, because they might not be accessing a support coordinator or a parent resource center that's not disability specific or whatever. Obviously, there's a lot of other limitations going on there. But so you're starting to hear this conversation from them as well. A number of those MCOs are as they are becoming managed care organizations in states that are taking over the long-term service side of states' systems. Sometimes they carve out DD very intentionally because they don't know what to do with our population. Some of them aren't allowed to carve it out anymore, and they're all looking for different strategies. The foster care system, with it being such a strong managed care system, they have come to us, and we're talking to them about navigational supports for kids in the foster care system. So the door is opening, if not open, in some of those places. And a lot of times they see it as just a benefit of their packages. And in some ways, those managed care organizations can figure out how to fund these positions much easier because they just build it in their budgets.
Well, and the issue is, everybody, I think, is familiar one way or another with the bright line between mental health services and physical health services. And so those are carved out plans. Those are funded differently. They're authorized differently. It does provide an opportunity to add supports, for example, in one of those where it makes more sense. But it often turns out to be the reverse, where the services are more limited. And so one example, I'm not going to name the insurance provider, but it's a very large insurance provider nationally and in Missouri. They will not cover developmental evaluations for children with what's called an F code, and an F code is autism. Mm-hmm. So if I have a child I'm caring for, and part of our evaluation is the developmental testing performed by our team, they'll allow the medical charge, but they will simply say, no, we don't cover that. So fascinating. Now, when I see that in one large healthcare provider, I'm waiting for that next provider to jump on that train. And I don't think, I've talked to some other people, I don't think this is unique to the St. Louis market. I think that we're dealing with this issue. I only bring this up because that's why we have people like stakeholders from Department of Insurance and state organizations and agencies, because we're going to need to have conversations with those people. We had a great partnership with Department of Insurance and all up and down the line when the insurance mandate was passed for coverage of behavioral and therapy services for children with autism in 2011. But that took a couple years of work. But we do have precedent for working together in the interest of the clients and the patients and the citizens, where things make good sense.
The place that you can impact it is when you're writing the RFPs for the MCOs. That is across the country, that is the place where you see the biggest impact in states. So when the state systems are going to go right, what's the big plan in order to become an MCO in our state? And the MCOs are paying more attention to the medical side, right? Because that's the biggest paycheck for them on that one. And so our populations are smaller compared to that, but higher cost to that. But when states write into their MCOs that they have to have certain things, when they're putting those proposals in, that's when you're seeing the most innovation, because that's then allowing you the leverage to hold them to it. And so, as states are courting MCOs for different populations, that's where the recommendations have to go in.
And I presume that would be the Department of Health or the
Social services.
social service. What combined name, right?
No, there's just the Department of Social. The Department of Social Services is the Medicaid entity in the state. So when they're writing for their contractors, that would be something that we could advocate potentially when we're doing that phase on access to care.
Okay.
Certainly, those would all be areas and things to look into. And can we include certain recommendations? It will, as she stated, it will only impact the Medicaid population by putting it in those contracts.
Right.
And I say only, but even in your practice, it's 40%.
Yeah, and it's
in other practices, it's can be significantly higher, and it is a good way to make change.
Yeah, statewide, I think the number's about 50% have public insurance of one kind or another. Children I'm talking about, I don't know across the whole population. Any other comments, questions, thoughts?
Yeah, I just want to say that it was wonderful. The things that you shared are the same frustrations that I have. The parent stories are the same things I felt when I was working with parents. And I'm a retired teacher, a retired special education teacher. Now I work at Jessie. And one of the things that, I could feel just how those parents, the desperation they felt at times, and just how it does impact families. One of the things though, when that I heard that just that advocate in me, as a teacher, you're advocating for your parents, you're advocating for your students, you're going to battle against teachers, you're going to battle against administrators. So I'm an advocate, and so I don't mean this in a bad way, but because that advocacy in me, is going to come out right now. But a couple of times you said schools aren't doing it, and I know schools aren't doing things right. They're not doing things perfect. But man, I hear stories, some success stories that a student is working at a hospital, and then they get a job at that hospital. I just heard that story last week, and they get a job at that hospital. So I hate to say schools aren't doing it. We can definitely do things better, but when we say schools aren't doing it, it's that language. How are we going to get more people to want to work in schools if we're saying that schools are bad, so to say? So I think that if we can change the language just a little bit, that schools need to do a better job of this, or that we need to help schools do this, because the people that are working in transition, they want to do a good job, and they need the tools, just like the parents want to do a good job. Those schools, and not every single teacher wants to do a good job, because some people just don't have that in their heart. But most of them do, and when they fail, sometimes it's because they don't have the resources there. So if we can we're going to talk about language and how to what's in a name. Well, language is important. So if we can just kind of say schools need help with this, we need to help teachers, because we're not doing well right now with recruiting teachers, and it's really making me nervous, and it makes me nervous when we say things that make schools that are derogatory toward schools. And I know that wasn't at all the intention, but if we can just watch the language, and I admit everything that schools need so much help, teachers need, there's a problem. And at the Thompson Center, I know that you see a lot of the problems that we have. But just that language concerns me.
Yeah, and I don't disagree. And I think that, which is why I did keep saying that I think that they need supports to do better too. But I also think that we need to be really careful because unfortunately the special education side of this is taking a hit as the excuse during COVID too. So how do we get the schools the resources and the support they need, the personnel and the funding that they need? But we're starting to hearing around that, like, and I understand it's a harder population to talk about, but we can't slide backwards in terms of our expectations and enforcement of what is there. Because it's like, we can't keep saying, well, COVID's the excuse and teaching's not the excuse, because that child's life continues, right? So somehow, how do we all help each other kind of over this sort of complexity that even COVID's added to already a hard conversation?
And I'm sorry.
I was just gonna say, there's no indication here, there's no appetite here with this group and this commission to paint schools as the bad guy, because there's complete and total recognition that schools are the heart of communities, and they are, right or wrong, the catch-all who's supposed to fix everything, but they don't get the resources to do all of that. And so with a lot of our stuff, we've highlighted things that are working well, and we have put schools in there, and we have put voc rehab in there, and we put DMH in there. But then we put these caveats on it and said they're working well when the person in that office or that school knows what they're doing and is working well. And it's very person specific. And when the person is good, system works. It's great, but it's very person specific. And when we have 20 to 40% turnover across all industries, and I mean, that just leaves it ripe for when the person goes away, the system breaks down. And how can we come up with those strategies to make it not so person specific, so that the system is not 100% relying on the fact that you're sitting in that special education chair and you're advocating for everybody in that district and you're making sure transition is starting at age 12. But when you leave, the next person thinks transition starts at 17 because that's when they're getting ready to leave. Yeah. So that's the lens we've been looking at it from.
And I want to amplify that point, because you can't work in this field or listen to people in our shared conversations around this table speak about this without remarking on the incredible variability. So, and one of the answers, and I think that kind of sandwich idea of the three buckets, call it, is great, because one of those is the family's in the middle of that. So yes, we're going to have variability among healthcare providers. We're going to have variability among schools. We're going to have variability among everyone. But the people who are going to drive the service, or at least are going to be potentially should, in my view, be driving the service, are the individuals and the families. So I think that I really like the point you made about when somebody comes to me and they have an issue, I start thinking about where I can send them. So I'm very service oriented, right? Oh yeah, I have a therapist for that, or we use this person, or we use that, or that would be a great school for your child, or whatever. But that's not the whole issue by any means, right? And so that deeper communication around empowering the family and the individual to be making their decisions and to inform them about the ways to get that. So that, I love the clearinghouse idea, or the hub idea that you're talking about, because then no matter how much variability I have in my large healthcare medical group, we can make that information part of the information which is shared with families. And they need guidance. I mean, it's not just go to a website or, go online and do something. But if there's a way to tie the door idea. So the way I think about that, and obviously that's a mature idea, I'm just thinking about it. But I think that there are multiple doors into a single space. That's how I think about this. People need a range of services, whether we say they need 4 or 6 or 12 or 19 in some of the lists that I've seen from their work. But there's a range of opportunities, and there's types of information that can connect individuals and families to those opportunities. That, to me, we're going to get to this afternoon, because I really want other people to think hard about this and come back. What are we really going to say? How are we going to say it? What are we recommending? Yes, there's a lot of things that are good. There are other things that could use some improvement. It's fine to call those out. But I don't think we've come up with a way yet to create this safe space for people to go. And that, to me, is going to be a part of a serious discussion, I think, if we want to get anywhere as a state. My opinion.
Oh, sorry, just real quickly, I'm Carrie with the Department of Commerce and Insurance, and I wanted to follow up on your comments about mental health parity, basically. And, you know, I think the biggest problem we see with that is that provider issues, people who live in rural areas. But I also wanted to point out that it's going to be, like you said, whatever is in the contract with that particular insurer, with that policyholder. But I also wanted to make sure you're all aware that those consumers can file complaints with the department also, and we can look into that, because it could be an issue where the company is maybe saying something isn't medically necessary. And we have options for sending that to external review to kind of look into that, to see if to have an independent organization look at that to see if it's, you know, and the person can also go through the appeals and grievance process with their carrier, but then we're also a resource to have an independent reviewer look at that. The other thing that I made notes on that I wanted to ask about was your workshops. So are those set up, how do people get access to those? Are those through your partners, or are they, how does that work?
Well, so it's not scaled across the state because a lot of the stuff is grant and research funded. So how we've been giving access to people is so we do a monthly open door series. So we did one yesterday, and those are free to anybody on there on the website. We send those out through all of the different networks and stuff. And then there are opportunities for people to sign up just to take workshops on our website. But we do, I mean, our idea is how are we building the capacity of local organizations and professionals? And so we do partner with them to host local stuff as well.
Thank you so much for this information. This touches me in many different ways. I have a brother with a brain injury. I am a CASA volunteer, so I'm a court-appointed volunteer for foster children. And then I'm sitting here, and so I see this, the broad ability to use this, you know, in so many different ways. And so I really appreciate the information. Thank you.
I think we'll go ahead and take our break. Is lunch here? Here. Just, I'm sorry. If not, we'll take a break anyway. And we'll, obviously it can be working kind of lunch, but I do want, I think, to continue the conversation that was started this morning. I think Stacy's going to talk to us about her experience and the issues that exist within DESE and their initiatives for transition, which seems like it's on point. And then after that, we're going to have our work group presentations are going to be much briefer today, and they're going to lead into a broader discussion about how we define our roles, how do we want to communicate the information, what other things do we need to be talking about before we start finalizing any sort of written communication. So we'll take a break for a little while, and then Stacy will get started sometime around 12, if that's okay.
Sounds great.
Sorry.
For those of you on the WebEx, go ahead.
I took all these things.
I went around and asked.
Yeah.
So I can be a transition liaison.
Yeah.
Is could they, what one of the important assessments what you That information is just hard for
Right.
people to process.
Well, so.
previously. I thank you for letting me share here today. I did speak to part of this group back in March back when I was with compliance. I let you know a little bit about the IEP process and about the requirements and how the IEP planning is completed and what our expectations are. So I understand today that I'm talking to you about some initiatives that DESE has going on.
She might be too far away.
I don't know, I like touching it. I'll move up there. I'll move. Sorry about that.
Pick one of them in the front, the camera will move. It'll work. It'll work for her. Yeah.
I think all of you guys know that we do transition planning because it's IDEA, that's a requirement. I also wanted to let you, I also just wanted to remind you, I'm sorry, when I was planning this, I didn't know the expertise of everyone, so I might be telling you stuff you already know. I'll try not to waste your time though. The Rehabilitation Act also requires transition planning, requires state agency and state vocational rehabilitations to work together to plan services for students. DESE has had many initiatives with the, you have to kind of see this, with the National Technical Assistance Center on Transition. We call them NTACT. NTACT provides tools, information, and supports to help DESE provide programs to districts, and it works with state agencies in a collaboration to plan things for transition and programs for transition. And we have 2 initiatives right now we're working on with them. The Transition Coalition studies, it was a 12-week thing, a 12-week program that districts can do with an RPCD consultant and with somebody from NTACT. NTACT is an organization that works with states, with the states in the country, to help give them technical assistance with transition planning. And so in the Transition Coalition self-studies, we had someone from the collaborative work with the school district personnel and work with a person from the regional professional development centers. And a regional development consultant we have 9 centers out in the state, and those regional professional development consultants give professional development and technical assistance to the school districts. And so that was one of the transition initiatives that we had. And we have one now going on that's going to start in the spring. It's an interagency collaboration. And with this one, the collaboration is going to work with school districts and their vocational rehabilitation counselor on helping them improve their services and helping them find ways to navigate what services they have in their communities. That one is both of these. When you work on an initiative like this, NTACT or the collaboration or their staff will help with planning it and will help coach the RPCD consultant and the school. So when they start out, it's someone from the collaborative, the RPC consultant, and people from the district working together. And then when that initiative is over, what happens is that the RPCD consultant continues to work with the school district. So we don't want it to be, you get this in service and then it's done. So these are not new initiatives, but I do want to mention them because they involve transition. The RPCD consultants work with the initiatives, but they also are there always to help give technical assistance to the school districts. They have a transition academy that's a 2-day long thing, not really that long, but it's 2 days that they try to give a course in or help to the districts in providing them information about transition planning, how to do the transition paperwork, how to do the planning, how to work with outside agencies. In school districts, there's, there's that turnover, so you're constantly needing to train new staff. And they'll also go to districts if districts request. And all of this is at the district's request. For those two initiatives, the districts volunteer. They will also go into a district and help them map out resources and develop plans in schools and communities to help them to find work experiences for the students, whether it might be an on-campus program or an off-campus program. So every district, is different. Those rural schools, it's kind of hard for them sometimes to really find something that they can do outside of the school. So there's some challenges that they're called to come help districts with. And again, the districts reach out to us, or if there's a problem with the district, we can highly suggest that they do one of these initiatives. Something that we have going on with KU is right now they're offering social emotional learning to schools. And again, schools have to volunteer for this. And what they're going to get on in this program, and I don't remember how many schools she's working with right now, but someone at KU and the RPCD consultants are working with the districts, and they pick out one of those competencies, and they're helping the school just plan ways to embed teaching that competency and into their instruction that they have, and giving them coaching and giving them instruction on how to do that. With these competencies, self-advocacy, self-determination, conflict management. Oh, look, I messed up. Sorry about that. When I was showing this to someone else at DESE to practice it, she said, well, why is this transition? It's social emotional learning. Before it was social emotional learning, it began as Missouri Post-Secondary Success. And it was aimed to give those soft skills to the students so that they had those when they went into the schools, and the soft skills to the schools. And the skills to the students to be able to be in charge of their own life a little bit more, So that did change to social emotional learning, and it's now going down to the lower grades also, but it started as really a way to help students transition into making their own decisions and transition into kind of being more of an advocate for their own desires and needs. I did show it there. This is not a new initiative, but I wanted to let you know we do have things for parents on our website about the social emotional. When we work with KU on this, we work with some really nice ladies, and what happens is we contract with them, and they provide us social emotional learning units. And so we have them on something called a virtual learning platform, and districts can use those as professional development for their staff. But we do have this on our website for parents if they like to look at, would like to be interested in helping this. Our website is really hard to navigate. DESE's a big organization. It has lots of different divisions, and the website is not the newest website in the world. If I were to ask anybody to look for this, what I tell people is just Google DESE social emotional learning parent modules to find something. That's the best way to find it. You could go to the new special ed webpage, but it's a lot easier just to put the title of what you want and the word DESE in there. This is one that I'm just so excited about the next thing, because the person is doing this is so excited. In July, we got a career special education needs improvement consultant. Her name is Amy Herman. She's had a variety of roles in her career, but she has been, her last role was director of technical education center. And she's going out to talk to districts, to talk to consultants, to talk to career technical education center personnel about ways to really include those special populations. It's not that the career centers don't want to do it. It's just, they just need to know how to do it. And the special education personnel need to know that their students have a right to be there too. So she's going out and just giving information about how to help the students get in there. She's trying to help on the state level to see if we can get some more resources to those career technical educators. I don't know if any of you guys know this, but career technical educators, like you take a welding, that welding person isn't a teacher. I mean, they weren't certified as teacher. They were a welder, and then they went back and they got part of the career technical is going back and getting the credentials to do the teaching. But so they didn't start out as teachers. Their expertise is in their field, so they need some support, and she's rallying for that support too. One thing with Perkins Act is important with career technical education, and you have to serve special populations. So she's getting that word out. What are the special populations you're serving? Are you including this in your special populations? What's your data look like for special populations? So she is really working to get data, and I'm just excited because I'm very hopeful that this is going to be an answer. And not one thing's ever going to be an answer, but I'm hopeful that this is going to help to open doors for more students to be in technical career education. Plus, there's a need for jobs out there. So if we can just build that job force, we're not only helping our students, we're helping our nation by getting jobs filled. So I'm excited about that, and I hope it goes well. You know, I hope my excitement doesn't get, my little bubble doesn't burst. Pre-eds, I think we all know about pre-eds, but I just wanted to mention it's underneath the DESE umbrella. We do have an interagency agreement that DESE works with, that vocational rehabilitation works with DESE. We're supposed to be working together to give those transition services. Pre-eds is also working, you know, every district has someone that can work with them for pre-eds. This year so far, 490 high schools have been utilizing pre-eds. Last year they had 569, so many do. There are some that do not. DESE is actually we have our superintendents are out of DESE for the state school for the severely disabled, the Missouri School for the Deaf, and both of those schools are working with pre-eds also. The Missouri School for the Blind is also, you know, out of DESE. They're not working with pre-eds right now. They're doing their own thing. I think that the blind rehabilitation specialists, you know, have been working with that population for some time, so they have some programs in progress. Next thing that I'm really happy that happened was the legislation was passed that requires every student to have an individual academic and career plan, which is also called an ICAP. And this is brand new that it's required. In the legislation previously, it said something like they may have or they could have or something, but now it says they shall have. So all students need to have that ICAP. And that makes me excited because it's our students with disabilities are first general education students. So if the general education has to beef up what they're doing to help plan for the future, you know, it's gotta be a way to help us, you know, to help with the transition planning, that those counselors are gonna be looking for more services. I'm hopeful about this. So that's just starting this year. But there were ICAP students did have ICAPs previously, but it wasn't required. And when our Amy Herman, our career technical education person, goes out and talks to districts, she has come back to me and she said that in some ways special ed is ahead of the game because they've had this transition planning that's been required. And we're teaching in some of the counselors and regular education, you know, some of the steps and some of the things that they can, services that they can have. The next thing I think did you guys have Impact talk to you at one point?
Resources need were approved.
Okay. Impact actually has a contract with DESE, and they have that as part of IDE. We have to have the parent training centers. So they have a contract with DESE, and one of the things in their contract is to help with post-secondary education. And so they have out in the state, I believe there are 17 right now, regional transition networks. And those regional transition networks, I'm sorry, I'm stumbling on my words, I'm kind of nervous. Those regional transition networks are, they are a group of people in that community, usually parents. Impact is helping to organize them, and they're having some transition networks in their different parts of the state. Like right now, Joplin, they have one, and they are going to have a job fair that's going on November 3rd, I think. So they provide programs in the area they're at, and they invite people from the area to help them with employment and getting students ready for life after high school. They're all not the same though, because each of the areas in Missouri are different, and parents are participants and leaders in this. So if the president that was, or the person that was, really active in the transition network, if they moved somewhere else and they're not active anymore, sometimes it takes a little hit, but Impact is there trying to continue to always work with them to help them increase their capacity. And that's a real neat thing. And they took a little bit of a strike during COVID, but they're coming back now really well, which is great to hear. And oh my gosh, I'm talking way too fast. I'm almost done. Almost finished. The next thing that we have at DESE, that goes on at the state level, is there's a Missouri Interagency Transition Team, and it's called MID, and we meet 4 times a year is what we have to meet. I'd like to meet longer, 4 times, but we have a goal with INTACT to increase the percentage of students participating in post-secondary education or employment. And I'm going to visit with INTACT next week to help them, to give me the tools to help to help with that goal. And another thing that MIT does is it does a Transition Training Institute. I know when I spoke to you guys last March, I explained, I let you know when it was. You're all invited. We are at the planning stages. So if any of you guys want to help plan it or want to be involved in the planning, we'd love to have you. If you know any parents that would like to be involved, we'd love to have the parents too. At the Transition Training Institute, there are sometimes we have schools that will show what they're doing so that others, if they have a successful program going with placing students, they'll share what they're doing. We talk about, there are some sessions about guardianship. Let's do supported guardianship. The concern that guardianship, is not the first choice. We want students after high school to live in the least restrictive environment also, and to function in the least restrictive environment. That's full guardianship is not the least restrictive environment. So we had something on that last year. So we're excited about, the things that we're doing. I've only talked for 20 minutes. I wish I was sitting up here talking for 2 hours to give you lots and lots more information about what's going on. But this is what I have for you. Do you have any questions that I can answer? And maybe there might be something else that I know of.
I wrote down several as we were going through, so
Thank you.
sorry, I don't mean this to be an inquisition.
No.
But you talked about those first initiatives where with the regional professional development centers that they are reaching out to the school districts and providing things on transition. But it's also from that same vein that we heard some other things, it's districts that reach out and ask for it and that want that help.
Absolutely.
So do you guys keep data, and are you aware to know which districts actually reach out and ask for that help so that there would be some way to say that, there's 524 school districts that, 10% or 80% of the districts are actually reaching out and getting that training to try and improve their transition services? Do you have that kind of data?
I don't know if I don't think we have that kind of data. I didn't bring my pencil up here, but I do, the ones that they reach out to us, but there are times like the RPCDs or, just from us working with districts, we'll see where they're struggling and we'll really encourage them to we'll try to encourage them to attend, to participate. But I'm curious about the data too. I would like to know that also. That's, I'm new to this position. That's definitely something I can start keeping track of and see if that training is making an impact. What differences it's making.
And then on your RPDCs that are doing that transition training, is that something that they are specialized in? So they, or is it like other duties assigned? Are they a jack of all trades? So are they someone who does every level of professional development for the
Absolutely.
districts? So
They do, it's not the only thing that they do, which would be great if each one had one person that only did transition. That would be wonderful. But no, that's a need to have somebody throughout the state that is the transition professional in that area, and that's all that they do. And that we meet on a regular basis, talk about transition, have, make plans together, work with Intact together to, really improve our services. But I see that as a need, because I just came into this job in July, and I'm the transition person. Like, my, where's my people? But I'm excited about going to Intact and to help me to figure out how to get those resources, or find out how other states are doing things. So you make some good points that, we do need the data, and it would be great if every RPCD, all 9 in the state, had one person that was just a transition specialist.
well, and especially now that it's part of the general ed with the ICAP,
Absolutely.
because in theory, every student is supposed to go through this and receive the services. So if every student is supposed to receive some sort of transition something, yeah, that's a lot.
And you know what? That's a really good point. You've just helped me out a way to try to push for it, because it's every student. So since it's every student now, those RPCDs do need one person that is special for transition.
Yeah.
Thank you.
You're welcome.
I'll go rally on that. I don't know where it'll get me, but that's really important. Yeah, that's an important point.
And then the last one that I had is, I think it's MSIP. That's what you go through and accredit the schools, right? With MSIP. In the MSIP program, do they look at, is transition one of the things that they look at? And I was thinking from special ed lens, because I didn't realize about the ICAP. So do they go through and see if the transition started when it's mandated to start, or has been started before it's mandated? Is that one of the things that they look at in MSIP?
I was looking at the MSIP 6 standards and indicators. And so they have, MSIP 6 has a whole thing of standards and indicators, and they have these little 2 stars by the ones that are monitored. And they did have stars by the ones that were monitored. They call it career and college readiness. And there were 2 little, stars by the ICAP one. So I'm not an expert on MSIP, but when I looked at the standards and indicators, they are in there that they're going to be, I think the 2 stars might have been, I can pull out my computer, might have been evaluated, or it might have been monitored, or data is taken on the career and college readiness, which includes the ICAP for MSIP. Well, thank you. Those were good questions, and you did give me some good ideas. So if you don't have questions, do you have some good ideas?
Thank you, Stacy. I think this presentation came about in part because I think Mark Wheatley at our last meeting brought up that in his role at DESE, he's become aware of increasing efforts. And I think you've done a good job of listing what those efforts are. I have the same question as Carrie's first question, which is, since transition services are an IDEA mandated activity, if I understand correctly, it seems like we're missing an opportunity without knowing for sure which school districts are participating and at what level. My guess is
Participating in pre-eds?
no, participating, it has a formal transition program that they're implementing in one way or another, through you or through some aspect of transition planning.
Well, in theory, they all are. Every school district
Well,
is doing it.
I was going to say that, but whether how do you know?
Right.
And what is the minimum acceptable standard of transition programming, which would meet the
Right.
goal of the definition? Because I can say we have a transition program, but how does that, and that's no different. I'm not picking on the
No, I know
schools
you're not.
because it's no different when we look at healthcare providers. Healthcare providers are expected to be providing transition information, all healthcare providers for children, beginning again around 7th or 8th grade. And we know from the data that it's less than 40% who say they do anything. And it's a self-reporting kind of a thing. So, it's hard. I don't want to be too cynical, but it's hard to know exactly what's going on in healthcare, just as it is what's going on in the school districts or
Right.
what's going on in any of these other little islands that exist out there.
That's why I asked about the MSIP, if that was something they specifically went in and checked. And I know not every school gets reviewed, it's what, every 5 years or something like that, they get reviewed. Or do they they don't get reviewed every year.
For special education, I can just speak to the special, I don't know about the MSIP, but I did see that those indicators are getting monitored in some way. For special education, as you probably know, we monitor transition IEPs every 3 years. Schools are where there's different cohorts. So every 3 years, schools are submitting information, paperwork to us, and we're reviewing the paperwork. If schools, we look at their transition planning, and the transition planning is not in compliance, it's not on the paper, what the paper says. And I know what the paper says isn't always what's happening. And sometimes what the paper says isn't like giving justice to what's happening, because a lot more is happening, they're just not documenting it. But there are times that, it's not happening very well. Sometimes the transition plans, you're like, oh my gosh, this isn't very good. We need more done to help the students. So if the transition plans are not in compliance, then they get marked out for being in compliance, and they have to do special training. So they'll have to do training. The training could be through one of our initiatives, or the training could be with the RPCD consultant. So they have to do the training, and then they have to show us, almost a year later, they have to give us samples of what they've done and samples of things that are done correctly. And this is paperwork, so but we do go into some districts and we do something called an on-site, and we check how they're doing with transition and what they're doing. And that's when we can really talk to them and give them ideas about, well, there's nothing going on here except they're studying careers, what career are they going to have? And so that's when we can give them some technical assistance, and the RPCDs have to go in there and work with them. So when they're not doing things right and we know about it, then we have the means to go in there and help them to correct things.
And do private schools have access to these services, or is this strictly public school districts?
The private schools are doing pre-eds. Some private schools, they can choose to do pre-eds. RPCDs, I believe they can go into private schools. I don't know if our compliance consultants can, but because they don't have compliance, because they're not required to have an IEP, it's not required for private school students. The private school students have something called an individual service plan. And so the school and the stakeholders in that community that use private schools or homeschool have meetings that is supposed to have consultative meetings to decide what the school is going to offer to the students that go to private schools. Public schools get money, called proportionate share, that they provide the individual service plan students with. I know I was working with a student at one point, and he decided to go, his parents decided to have him go to a private high school, but then when it came for his some of his transition services, they tapped into the independent living center that helps provide his transition services. So for private students, it's not required because FAPE is not required, but districts and communities have things that can be used by both by private students also. Did that answer your question?
Yes, thank you. Any other questions or comments for Stacy?
Well, I really appreciate what you guys are doing. Candy, who's come to some of your meetings, was telling me about what your final products are. And I'm just, groups like this can really help get things done. So I'm excited because we need this help.
Thank you. Thanks for the work and sharing your information. Appreciate it. So think we'll just go ahead and stay a little bit ahead of schedule because we'll always find something to talk about eventually. The next agenda item, I think everybody has received or did receive at least a copy of the article that I came across a month or two ago, which I don't speak as an authority on these issues. I'm not an individual with developmental disability diagnosed, and so I am only serving as a filter here to share the information that I thought could be relevant to the commission. I think all of us that work in the field, and again, it tends to be variable depending on which part of the elephant you're holding on to, but all of us that that either work in the field or have experience individually or collectively receiving services or diagnoses are aware that the terminology and the naming around all disabilities is something that's under review and being discussed. And so, do you have my slide there? I simply summarized my take on what this article is, and so this was simply a FYI for people to, if you haven't come across this issue in your own situation, to realize that it is receiving some discussion and some serious attention, both from individuals in the neurodiversity movement, as well as individuals with various diagnoses. I think the key thing, and it probably isn't relevant to everybody here, but about 15 or 20 years ago, one of the organizations that I belonged to that worked with another group of individuals with disabilities, it was with cerebral palsy, began adopting a model in which the concept of disability was reframed. And it was reframed exactly as it's described in this article. So this is not new in any way, shape, or form. That a disability is not something that a person has. A disability is a net effect of an individual's variation impacting with the environment and opportunities that they have. And as I say, that's probably not news to most of you. But if you're an old doctor like me, whenever I learned about disability, it was something we learned about as being intrinsic to the individual, and it never really considered the multiple dimensions that impact people's functioning and participation. And so I thought that that was helpful. So summary slide. So, and it gets right to where a commission can have some impact. So how the environment supports or fails to support a person's needs is critical, of course. There's mixed reviews on which language is preferred. What's pretty clear, and it's a little embarrassing as I sit here and look at the title on the slide, is that the concept of disorder, disease, and dysfunction is being really marginalized. And so normally it would be easy because we could simply decide that we would call ourselves Missouri Commission on Autism. But this is the name that's in the statute. Doesn't matter? Okay, well then I would submit that that's what we should do. Unless there's opposition from anybody. Good, I didn't know if we had that autonomy or not. I'll take your word for it.
I mean, the statute's not gonna change. The statute will say what the statute says, but what we put on a piece of paper and when we have our meetings and what we put on the top of the agenda, we can say the Missouri Commission on Autism.
Yeah.
And everyone's going to know that we're operating under that statute.
Okay, good, perfect. So again, the issue, this was something that was a few decades ago was considered to be a step forward, which was to use person first language. So a person with a diagnosis or a person with a condition. And so again, because of the recognition in terms of the ongoing conversations around this topic, there's the identity first language is often preferred now. So it's an autistic person. And that was really it. So just wanted everybody to be aware. I wanted on the record that the commission is aware and that we are doing our best to be sensitive to those issues. And open to comment or discussion.
Yeah, I think there's real heterogeneity there, right? And we are challenged in a group like this when we write something because we have an audience that's going to reflect that full range of heterogeneity in terms of how they consider terms of disorder, disability, impairment, etc. So finding a place to just name that and recognize it, articulate that we're sensitive and that there's no perfect way to communicate this in one place to everybody could go a long way. That's different when we're talking to an individual. So I'm talking to an individual, I can just ask them, well, how do you like to be referred? And I'll go with that. That's part of just that respect between me and that individual. But we face a different kind of challenge here. So.
And I would agree with Stephen on that. As an agency, DMH will continue to be person-centered first. We recognize this and we understand this, but it's not fully 100%. Everybody says that they want it, that we need to identify someone as an autistic individual as a person, as opposed to an individual who has autism. And we have multiple other within our umbrella of DMH. And so at this point in time, DMH will stay with our person-centered language, not because we are ignoring or don't want this, but we have lots of interests through the way. And we also on a piece of paper can't put autistic individual / individual with autism on everything. We don't have room to put that under everything. We want to be as inclusive as we can be. But for right now, we're going to be staying with the individual and doing the same, like Steve just said. But when we're dealing with an individual and the individual says, this is what I want, then yes, obviously we work directly with that individual. But as far as in our publications and things.
There's also, I think, times where we're writing things where we can be overly tortured about our language that gets in the way of, frankly, just the readability of a sentence. And we need to be clear communicators as well. So that's part of it. The other thing I think about this a lot that we're really challenged with is the science is moving. And some of these statements come from one particular part of the community of people with autism or autistic people or the individual that we describe. And it doesn't speak for always everybody. And I think the science is moving and frankly, I think a bit of a mess in terms of who we think of as falling under this umbrella of this diagnosis. And I think the field is not fully and effectively grappled with where those diagnostic boundaries are, what we mean exactly by spectrum. I think there's quite a bit of variability and lack of scientific rigor there in the field. And so I just say that because what we say now, the field's going to evolve, and in 5 years, it's going to be something different because we will do better at that over time. And so we should be broad enough that we can sort of future-proof a little bit what we said.
Yes, I appreciate that.
Jack, can I just say something real quick?
Oh, yes.
This is a very hot topic in research, those of us that research autism, and I'm working with somebody on writing a paper along with some autistic individuals about it. I think that the only thing that I ask is that we don't, and I know people with disabilities and disabled people have asked to not use terms like handicapped or special needs. That makes me cringe every single time it's used. To not shy away from the word disability. You know, if you read and talk to people with disability and advocates, that's disability is their life. They have many intersecting, ways in how they identify. And so they don't want us to shy away from it. It should be normalized as quote unquote, it can be. So if we come forth and we have a very strong way of saying things, and we don't use those, very demeaning terms of handicap and some of the other things, we can be a good model for them. That's just what I ask for the commission to maybe present for people who might not be as embedded in this field as we are.
Any other thoughts? Anybody?
Jesse's had this talk too. We had the same talk that Carrie was talking about. We're following.
Okay. So we're all aware, we all recognize that there are different perspectives on the topic, and we're all going to be as respectful as we can in terms of the group, to the extent we have to call it something. So we'll move forward in this fashion. So thank you all for being patient with that. So I think we'll go ahead if Lindsay and Seth are ready to review the work of their specific subcommittees in terms of best practices and recommendations. Lindsay, we'll go ahead and start with you.
Want me to pull up that document you shared?
Yeah, that would be great. I'm just pulling it up on my own. Yeah, so the best practices group has been, we've met a couple times since the last, time. And we've tried to really narrow down, the best practices that we want to recommend. And we do need information from the other side about what is going on in the states as well and what we have access to. But we did work on this document that we have here, and it'll be refined however we need it to be refined. But we broke it down to what an individual with ASD in high school can do as best practice and what a professional can do as best practice at that age. And so we talked extensively about engaging with assistive technology to assist in planning, independent living, employment, and education. So we know there's lots of research out there showing that video modeling and apps and other assistive technology is helping people make progress with their post-school outcomes. We know that it's research-based and it's supported. We also know that participating in self-determination, advocacy curriculum or programs such as the SDLMI, the Self-Determination Learning Model of Instruction, agency programs. There were some other projects and programs that we were identifying that we'll add in websites for as well, just so that people have access to them. But we know that having a more improved self-determination helps with post-school outcomes and what they want to do. It relates back to what Dr. Reynolds was talking about the life course, and really focusing on what the person wants versus what we as professionals recommend. We also know that participating in paid work experiences in high school or on your own is very valuable. We know VR has some summer work experience programs in the state. You have to get some of those outcomes from Luke, our VR rep on the commission. And we suggest that they also request to be included in general education, because we know that inclusion across the board in all aspects helps promote post-secondary outcomes. We also felt that participating in a 5th-year internship program to build skills and network also helps. We have information and research showing good outcomes with vocational training programs, comprehensive transition programs. Project Search is an employment type program that has positive outcomes. Again, Luke is going to get us some VR, some Missouri VR numbers. And then our healthcare team gave a bunch of different suggestions for certain ranges and ages that what the healthcare professional can start talking to and asking for throughout the years. And then we also talked about so that's just the individual with the autism, what can they do at that time? And then we talked about what a professional can do as best practice. So any stakeholder that's involved with a student or a child with autism. So it's, the school system, it's VR, it's case management, all of them. We said that they could work on learning about remote supports, providing support remotely in the home. We have emerging evidence that that is beneficial from Tim down. He's right there on the video about how that can improve independent living and promote that independent living for students. Professionals can also research individualized support living and how it can assist your students. It goes along with the remote supports. Again, researching different assistive technology supports for employment, post-secondary ed, and independent living. So understanding and really knowing what are the best practices out there. And if we have something like a website or somewhere where they can go and identify these types of practices in a central place specific for Missouri, it could be pretty beneficial. Because that always seems to be the deciding a factor. The transition specialists are always, constantly wondering what can we do? I mean, we're sitting here wondering what's in the state, what's available, being able to provide that for stakeholders. Connecting families to targeted case management, which can coordinate services, resources, waivers. So kind of that peer support role that you were talking about. Can help with charting the life course. They go through DMH with the first diagnosis, really wanting to have a type of family advocate throughout the life. So whatever you call it, somebody who can be with that family the entire time from diagnosis to whenever they feel they don't need them anymore, to help navigate those transitions, especially transitioning from the school system and IDEA to adult services is a huge transition, and a lot of families and parents don't know what's going on most of the time. So really having somebody to help them with that connection. That doesn't necessarily mean that that's in the school system and that it's, forced upon the school teachers on their plate, but it's somebody else that may have more knowledge in an outside source that doesn't have that kind of connection. More of a, not an outsider's lens, I can't think of the word right now, but objective viewpoint. I worked in the school system for a long time, so we definitely have an idea what's going on, and so we don't want somebody to have, maybe bring that negativity to the table. We'd like them to implement and promote universal design for learning, which is a framework for teaching, and it's good teaching in all classrooms in general ed as well as special ed. Building relationships with employers in the area, make connections and networks of employers willing to hire and intern individuals with autism. Especially, we talked about this being very important in the more rural areas because you don't necessarily have huge, hospitals or corporations like you do in more of the urban areas that might be able to have those connections. So you really do need to have somebody going out and reaching out and making that connection with that employer. Researching different accommodations, adaptations for sensory issues, plain language and documents so people can all read it and understand it, and be willing to share and distribute. So if we have somebody in Kansas City who has really nice descriptions on X, Y, and Z, that they're able to share that with other people as well and not just kind of harbor it for their own folks. Professional development for agencies, healthcare employers, provide new research, evidence-based practices. we talked about this being twofold, requiring professional development for stakeholders, and then stakeholders providing professional development for employers and agencies. So not just, you know, the direct team that works with the individuals with autism, but also them then helping and educating those who would work with the individuals in society. We'd like them to identify and share post-secondary ed degrees, options, programs in the state and the nation, and encourage post-secondary ed as an actual option for individuals with ASD. We have several projects, Project Strive, there's Achieve, there's several different ones that are at college levels, as well as college programs that people are just not making, that they just don't know about. And again, we have in there in the healthcare what the professionals can do, what the doctors and medical personnel can do, learn the steps to prepare for patients for transition, anticipate guidance, stay connected, and engage the autistic team, help them develop their voice for healthcare issues and concerns, because they're going to need to know that stuff when they go onto an adult healthcare provider. And so then we broke it down into recommendations specifically for Missouri best practices. And so that's where we need the practices and places from the other groups so that we can align some of these best practices, like what is going on in the state already. Healthcare will need to develop methods to publicize and provide readily accessible information, website recommendations for all involved. What a professional can do as best practice, we can definitely start with charting the life course program, starting to get that out, building relationships, networks with post-secondary ed institutions and programs to provide opportunities and information about it. And again, building those relationships and networks of employers, educators, stakeholders, independent living agencies, really working and promoting a more interagency collaboration across the board. So working together versus in our separate silos. And then we discussed a little bit about implementation strategies, and we didn't even talk about projected impact because we're still working on other ones, but these implementation strategies were targeted ideas for best practices. Where can we potentially encourage policy change or request funding from the state for pilots to see that we know this works here, we'd like to expand it to here, so that eventually we could, you know, promote it across the state. And that was just a few of those that we had come up with. Any questions? Did I miss anything?
Anybody have any comments or questions? Pretty exhaustive list.
Oh, you're right.
Spencer, did you have something?
No.
Oh.
Oh, he just wrote that over on the side.
Oh, that was.
Oh, that was
just
the
part of the document.
edit memo.
Okay. All right.
Because one of the things I think goes with that, what Spencer had put on there, was the dissemination. How are we going to disseminate this information? How are we going to get it out to doctors? How are we going to get it out to educators, et cetera, and stakeholders? So that's a great question, and
yeah,
hopefully we get an answer.
Well, I think that is a very good question. It's an important question. And hopefully we're going to get to some discussion on that point in a little bit after we hear from Seth.
Yeah, sure. So Jeannie Marshall was is the chairperson of our subgroup, and Jeannie could not be here today. So a lot of this information that Carrie and I are going to share this morning has certainly been spearheaded by Jeannie, and thanks to Jeannie for all of her help on the subcommittee. But I think we took an approach similar to what you were saying initially, where our initial efforts were to try to identify everything that exists in the state. And as a subcommittee with 10, 12, 15 people on it in different regions, we quickly discovered that's an impossible task for us to accomplish, unfortunately. Because, you identified a second ago, one of the things that we need is a directory, a hub, something that people can go to and find out what exists. It doesn't exist, and it's hard for us, even as professionals in the field, to figure out what all is in existence. So we took a little bit of a different tack after about 3 months of reflection and discussion, and started to look at the task that we were given from a broader perspective. And Carrie did a lot of work, spearheaded journey mapping. And we shared an incomplete journey map at our last meeting 3 months ago. Ironically, we got a lot of this journey map information which Carrie will share from Minnesota. So it was really great to hear Shelley talk about they do ongoing work with Minnesota. So Carrie, do you want to share a little bit about our journey map process and where we are?
Yeah. And actually, we can pass these around. And what they're passing around for those who are on the screen, I'm sorry, I'm gonna have this electronically, but I don't have it in here for Crystal to pull up electronically. It's the same thing that we looked at when we met with this bigger group last quarter. And so, as Seth said, we started off trying to put together that listing of services. And the truth is, Missouri really does offer almost every service there is for autism. It's somewhere here in the state. It just depends on where you live, of whether it's is there or how long the wait list is. So even putting together that really comprehensive listing of services doesn't tell our story, because there are always geographic or budget or any other kind of constraint. So in theory, that service is there, but you may or may not be able to access it. And if you can't access it, it might not be for several months or maybe even a year or more. So instead of trying to delineate that all out, we did switch gears and did a crude attempt at journey mapping from some different perspectives. And the reason, for those who have this in front of you, you see color coding on there, you see the gray boxes. That gray box just means, well, we tried to look at this from 4 different perspectives. The first one, the one that you have, is an individual who doesn't have a medically documented diagnosis and is not currently enrolled in any state programs other than special education. Those were the things we tried to look at differently. Do the needs change? Do the barriers change? Do the possible solutions change if you are a person who has a documented medical diagnosis? And what we really kind of found was, well, just a little, not a lot. Most of your barriers remain the same, but you do have, I won't say a leg up, maybe a step up if you have that documented medical diagnosis versus someone who doesn't. So that's kind of how we were looking through these. And so we did try to line out, there are certainly phases of transition. There's the pre-planning phase, assessments, trying to figure out what the individual needs and wants and what their future looks like. Fits nicely with the Charting the Life course when you look at it from their perspective. And then the actual transition phase as folks are going through that phase. And then certainly implementation of different things to help that individual fully transition into adulthood. And we had to keep pulling ourselves back because we are focusing on transition to adulthood. Life is transitions, and so we would fall down some rabbit holes. But we had to keep coming back to it. We were tasked with transition to adulthood. And we also had to keep pulling back that our task as this committee is to put forward a report that has recommendations to then be implemented later. It's not for us to, you were saying, how do we get the information out? That's actually not our task with this committee. Our task at this committee is to determine what information what resource do we need, and then make the recommendation that we think Missouri needs this. We don't have to recommend how Missouri gets and implements this. We're just Not yet. That's not our task yet. Uh,
Thank goodness.
right? So we had to keep pulling ourselves back from that as well. And when we were going through this, we were trying to identify how do people come into the system to receive some sort of services. If they have autism, is it through their doctors? Is it through early childhood special ed? Is it through the school districts? Is it because they sought help from community supports, their churches or whatever? So we tried to be as broad as we could in identifying how folks come into the system. We tried to then separate out what state agency is connected or would that individual go to, because it's hard to navigate the state agencies and to know who gets what and who goes where if you have a concern or a problem. So we were trying to line that out. Happens to be the same agencies across the board for every stage of transition. And then we tried to identify what was working well, and this is where we alluded to with our conversation with Stacy earlier, that it really is person specific. So we have a lot of systems, just like in the medical system, you know, DMH, the school district, whatever. I can go to a healthcare provider and I can find a really, really good doctor who I like and does everything that they need. And then that doctor may retire or they may move out of state. It doesn't necessarily mean that health system, that doctor's office that had 3 providers is doing a good job that I like anymore because my doctor's now gone. That is the same across the board, whether you are, you know, working in vocational rehabilitation, whether you're someone working in a DMH office or a school district. Our systems don't seem to have the right barriers or the right protectants to keep the system going when the person leaves necessarily. So there's definitely room for some discussion on how we build those structures and supports into our system so that when the actual employee leaves through retirement or whatever, that the next person coming in line, I won't say seamlessly because that's a pipe dream, but pretty seamlessly can pick up and still provide those good services to folks so that the families aren't the ones who get dropped. And then we focused really on the barriers. So we had lots more barriers than almost anything else identified of where can people fall down in this system. And one of the big ones that came to light is parents start the process too late. And that's mostly because they don't know that they need to start the process for transitioning a child out of high school in maybe 7th or 8th grade. They don't, they're too busy trying to get the kid to school that week in 7th or 8th grade to be thinking about the future that's 7 years down the road maybe. So frequently they start the process too late, and that can go across the board. You know, the doctors to try and get the diagnosis if you don't have it, all of those kinds of things, they can start too late. So that was one that we really hit hard on and talked about a lot. One of the other ones that we kind of kept circling back to is parents. We have a information overload on the one hand, but not enough information on the other. And so really it's just a mismatch of the information. It's not timely to the parent when they need it, when they're ready to access that next step or absorb that next step of information. They don't know where to go or where to find it. Or there are times I couldn't find stuff. And I would like to pride myself on knowing I know a little bit about DESE, I know a little bit about health, I know a little bit about mental health. I even know a little bit about the Department of Insurance. But trying to find resources, there were times sitting at my computer going, I know this exists. I know they do this. Why can't I find it? And that's when I'm specifically looking for something, and parents don't even know it's there.
Right.
But then on the other hand, going down rabbit hole after rabbit hole because I found, oh, this website's good. Look at all these things, and I'd go through. Now I forgot what I was doing because it's just overwhelming. So we don't have it well organized, and it's not out there, and that's resulting in parents not knowing. They give up. They don't have time to go through all of that and try and find it. And so that's something that we found again and again. And then of course there are the ever-present barriers of insurance coverage and access to services and wait lists and all of those kinds of delays. Difficulty to navigate and get into state systems and state services, and what is our application process, and how do we go about it, and how do I remember the 25 things that I needed to include with my application so that I don't get kicked back to the start of it again. All of those present barriers where the families can throw up their hands and say, well, things are good enough for now, so I'm just gonna keep going along until they kick me out of this system or I reach my age level. And then again, it's back to the other barriers. It's too late to get started and get these things, and now we have gaps and families are struggling. So I'm not going to go through all of the things that are on there. I'm going to kick it back over to Seth. So looking at it from that lens of what are these barriers, where is the risk of failure for the families to throw up their hands and to step away from the system until they absolutely have to come back to it. Using that lens is where we then said, well, what could we put in place to prevent that failure risk from happening? And so I think Seth's going to summarize some of the things that we have on there, which I alluded to earlier actually goes pretty well with the presentation that we had from this morning. So I'll turn it back over to Seth.
Yeah, hey, Catherine, do we have that, the sheet that we compiled that has all the, mirrors the sheet that we just shared with, I should have contacted you and asked you to put it in the
I probably
presentation.
wasn't here.
Yeah, well. But, while we're getting it pulled up, because I think visuals are helpful, I won't spend a ton of time on this because there's way too much information for us to, dissect line by line. And that's, I think the more important conversation is the conversation that we can have as a group. It's what do we do with where we are? Where are we going from here? But, Carrie identified a lot of what we termed failure risks. We know that there's failure risks. We hear anecdotally from parents, families, similar things, yet unique things depending on where the person is existing, is living, because there is a whole lot of variability. Somebody said something about variability earlier, and that's 100% accurate as far as services that are available. So we took those failure risks and we tried to turn it around. That's exactly what I'm looking for. Perfect, thank you. And we tried to turn that around and consider, so given that we know that these are problems, what can we do about it as a state? What can we do, narrowing it down even further to our work as a commission as far as our recommendations? And we liked the framework that the best practices subgroup you utilized, and so we borrowed your document, and we appreciate you sharing that. And we really focused mainly on the implementation strategies. We put a few things in there that are worth reviewing and understanding, and this can certainly be distributed to everybody later. But if we scroll down to where it says implementation strategies, it's probably on page 2 or 3. Yeah, so that's really where we viewed our subgroup's task, to sort of figure out, so what can we do, what can we recommend from an implementation standpoint that would be useful. And I was listening to Shelley's presentation earlier, the concept of the Minnesota Disability Hub, and that care pathway, the life course, from the individual's perspective. I kind of wish we'd have had you talk in our very first meeting, because I think it would have helped us kind of frame the direction we ultimately ended up going a little bit quicker. It was just really great, a great way to conceptualize it. But like you can see, 1, 2, 3, 4, 5 bullets down on that page. Create a single point of entry, streamlined application and referral process for state agencies and applicable programs. Create a streamlined application process for Mo Health Net. Those all have at their roots trying to identify some sort of pathway that the families can access when they're ready to access that pathway, and follow a path that will chart a course for them to access the resources that are available. Do we know exactly how that needs to look? I'm not sure that we do. I listened to Shelley talk. How long have you been working with the state of Minnesota on this? A number of years, and it's still a work in progress.
They said that they've been working on that disability hub for like 25 years.
For 25 years? For 25 years?
Mhm.
Don't be discouraged. We can use all of their work.
That was my initial call. How do I clone that?
So, but that's the thing, you know, what can we recommend, where we sit is what can we recommend as a commission? To start down a pathway to make this, like, to create a system that's accessible to the families, keeping in mind the failure risks that we identified, and also keeping in mind, hey, these are some implementation strategies that we could set up, that these are paths that we could follow. And I think the $1 million question, and I think, you know, when we met a couple of weeks ago, and it was a very useful meeting when Dr. Manavani and Jeannie and I and Catherine met, just to kind of talk about where do we go from here. You know, I think the useful discussion as a group is how can we take the information that we know and pile a set of recommendations that the legislature can use. So that's kind of where we sit as a subcommittee. You don't want me to go through any of the more specific implementation strategies at this point, or should we just turn it over to
Whatever people's pleasure is. I mean, I think we're all circling the same big subject here. And I think the details are important. The work that's been done is important. But I think we do need to talk about what is the process, what is, at least to some extent, what's our core recommendation going to be? And I think that we all agree that it's probably not adding more bullet points. It probably is an umbrella of some kind. And then connecting that umbrella to the various folks, the individuals, the families, the providers, you name it. But we can talk about what the challenges will be around that. But I think that that's sort of where I am at the moment. And that's what I've taken from these other discussions. So anybody, are people ready to have that larger discussion? I think we might as well take the time to do that. And you guys are probably the closest to having thought about it, because I have not reviewed the Minnesota data myself, but we have people in the room who have, and Shelley's graciously agreed to stay and get home later so that she can participate in this discussion, and I'm going to look to her to. But I am going to force the issue consistently about what's practical, what's doable. What do you mean by that? Because all these ideas are great. Let's do everything for everybody, but that won't work. So what are we going to do? What are we going to do? To Carrie's point, what are we going to recommend? Will get us and our families where we want them to be.
Yeah, I completely agree with that. One of the things that I personally experienced in working with this group and going through stuff is Missouri's information right now in particular is incredibly disjointed. And so there's impact, I'm sorry, the governor's disability group, and there's what you guys are doing at UMKC, and there's just all these different places, and the more I would look for something, I'm like, oh, well, that exists over here. But the problem is we have 100 things and they exist in 100 different places. And so I feel strongly that at least one of their recommendations should be, and I'm going to use the word no wrong door, and I don't really mean that because I know it has a whole other connotation, but we need to have, and it does have to at a minimum start at a website that consolidates this information, and not in a listing. And not one that's designed most likely by a state employee. No offense to state employees. I've even done some redesign stuff on some websites. That's not what I go to school for. And that's not how you come up with a really efficient and effective website that can do some of the things that we're talking about, that allows a family to come to that website, whether the child is 2 or 42, and be able to say, oh, here's the link I click on, or here's the tab I click on to get me to where I need to go, because that's where I am in my journey, and direct me to somewhere else. To what, so if I'm at 42 and I need X, I can go there and I can look through and find out, well, you should probably talk to the Department of Health, or you should probably look over here at this. So it won't be the end all be all, but it would be something that's easily digestible that can help connect them to stuff. And there'll have to be that other component. That's not the hub. That's not the Minnesota Disability Hub. It doesn't just stop with that website. But that's, I think, a minimum of something that needs to be recommended.
Yeah, and it's interesting. So if you like look at the course of the history of like the internet, or even like I like to take things back to like, you know, back in the day, parents will tell you, where's my resource directory? Here's my big notebook I carry around about all my kids' stuff, right? And so you start thinking about this, like go back to the old school paper things. Those things are the things that are still needed, right? And technology in some ways has helped and created chaos in that arena. And I think that what's been interesting about Minnesota's conversation, and so it has taken 25 years to get where they're at, but she walked me through the timeline and the phases about how do you leverage the different opportunities with the state systems, and how each time it kind of built another component of it and brought something else in. So, you know, they started small, and my guess is that, you know, the concept around aging disability resource center started. So it was really strongly independent living center and aging, and then it's expanded. And then if you start looking, and you know, we're talking about different unique populations. However, when you start looking at the government resources, they're not unique. Housing is housing. It doesn't matter if you have autism or not. You know, school is school. There might be additional sort of interventions specific to that target audience. So what Minnesota started to realize is stop creating all of these pathways by diagnoses, right? Start looking at those pathways by kind of outcome areas. And what are some unique things because of populations, but don't make all these, you know, an autism resource center, a Down syndrome resource center. Like it doesn't, you can't manage them all. The other thing that I've always said too, and this is what she kind of validated in this conversation was, trust me, I've given her a million questions. I'm like, oh my gosh. So she, they're not there to take away or duplicate something else that exists. So in Missouri, you know, this was probably before I was working in the field, people always used to talk about the Governor's Council's Blue Book and their binder, and it was like their Bible to resources. Well, that became their website. Well, how many people know about their website, or does everybody else go and create their own websites? And so, you know, if the government is investing in a Governor's Council website, then why aren't we all using that as our directory, not creating a new one? And then their hub is not a directory. They don't want to maintain it as a directory. And their website is just the landing spot to actually get to their 47 information staff. So their hub is an infrastructure that they said, you know, that's the other thing that you saw. I mean, Missouri went down this path, you know, 10, 15 years ago, like let's get a great disability resource website that needs to be populated grassroots up. That never works. Or by state staff just saying, add it on to that assistant's job, or we'll have an intern for a couple of months, right? And so, you know, they have a team that does nothing but content. They have a team, and so like, and then they have those sort of information navigator staff that then they also train them and keep them pretty, you know, they control their quality of the calls and how they're supporting that. The other thing that she talked about that I thought was really interesting, and all of these things actually fall in with the no wrong door governance conversation, quite frankly. They have it so that their staff actually have access. They can't manipulate anything, but they have access to the internal state, like Mo Health Net records and stuff, so they can see where things are getting held up. So they're not just saying, hey, fill out an application. They're saying, I see where it's stuck in the process, or they can actually understand what state resources they're accessing, and so not only are there some of their technology systems interoperable on a whole other conversation, but then their staff can look into there and kind of see where things are stuck. And so, I don't know if I answered your question, or even if you had a question. No, but so the other thing they said was like, Missouri just rolled out a senior disability line. I don't know how many of you know that, or why you even think it's relevant, but many people with disabilities can start accessing a lot of the senior services at a younger age. But the other reason why I think it's relevant is how are we looking at the infrastructure of stuff that's being rolled out in the state that's being statewide, and that how do we model that for this kind of conversation? When does somebody with autism go to independent living center? When do they go to special health care need and access EPSDT? When do they access regional office? You don't know, and you can access any or all of those at the same time, right? So the AAAs, which is the infrastructure, the aging system, have now a senior 800 number that everything that goes there funnels into their local centers. So the conversation's happening in other life stages within the system. And so it does, I think there is an opportunity for that. I think it's bigger than autism. I think you'll go backwards if you make an autism hub.
Absolutely.
And I think there's too many other things to leverage because, just even the conversation about schools, right now, even before COVID, all students need help with transition. And some of the stuff that families, when we're talking to families of children with autism or upper disabilities, we're helping help them understand that all students need social emotional support right now. They all need self-determination skill sets. They all need executive functioning. There's obviously additional barriers because they might have a diagnosis. But, we're seeing later and later that, kids are living at home with their parents much longer. It's not just an autism thing. So how do we help people recognize that some of these are things that are happening in society? And I think that that's why some of these pathways are important to get people away from the diagnosis or some of the services as their golden ticket or answer. Because they're looking for a quick fix, right? Where's my kid going to move out to when they turn 18? Or and so how can we help them understand? On this document I circled, you said parents start the process too late. Well, what is the process? Like their kid in school learning social skills? Like what's the process? I think we've made it so formal that people think that the process is actually what's supposed to get their kid ready. So the Disability Hub said that they won't let any vendors put their information on there. They won't be a list of directory. They'll access the list of directories that are provided, but they're intentionally trying to help you make an informed decision. And they said they have fought that over the years because people are like, well, you should put this on there and you should put this information on there. And they're really careful about what their role is and it's staying distinct.
Where is that hub and that staff, where do they live in Minnesota government? Whose department are they in? And how does that, and do you know what the budget is for that? And do you know?
I just asked them all those questions.
Okay.
And I can get more of that information out. And some of it I'm probably not going to share publicly here, but I can share that behind strategically with you guys, some of it. But she's working on the budget because some of the stuff that I wanted to understand was what's the difference, what's the cost of launching the website and maintaining a website? Because that's the other thing other people overlook is that websites aren't just like the brochure to your organization anymore. It is an educational and training tool. And so there's real costs with maintaining that, putting good content on that, ensuring that it's accessible, like not just accessible to the information, but the accessibility standards that they set in Minnesota are just completely, really amazing. They are housed, I think, in Health and Senior Services. I need to double check where that is. But they contract out to, and again, remember it didn't start on the DD side of things, but they contract out to the independent living centers around the state. And they employ those positions, but they're 100% trained and basically employees of the hub, just housed inside independent living centers. So they subcontract with these independent living centers. She said, all of this evolved over opportunities over the years. So she would say, I'll tell you different ideas on how you should roll yours out that we weren't faced with. But then what happened is different departments started to realize that in their federal mandates of needing to educate, instead of having their own, how could they invest in this? And so I think she said Voc Rehab invest into it for the employment pathways. And so there's different ways that it's not all one entity running it. Truly is a sort of a cross-government type of.
So the thing that I heard you say earlier, and I heard you say again, is that this needs to have some sort of reality. And so I guess because of where we are in the current climate, there will need to be a web presence for this activity. However, the cost is going to be in the people and the training. I mean, we've all talked about this, like where you join the system, if you happen to have a great occupational therapist, whenever your child is 6 years old, he or she may be your advisor for the next 10 years in terms of helping you navigate, because he or she's become a friend and invests in your family. It's like having an uncle that knows something, or like having a hairdresser that knows something. So, but what they did was they said, we're not going to trust to the arbitrary opportunities of people meeting and getting lucky by the people that are in the school or their healthcare. We're going to create that. We are going to create a population of experts, and we are going to invest in them and pay them and train them and support them in ways that would, I hope, make their jobs rewarding. That's a big, big deal. We all know that. But if we have a model which has shown success, and if we have the opportunity to learn from that model, I think it's worth continuing conversations. Obviously, you're going to be having conversations. Now, do you have designs on bringing that to UMKC, something similar? You said you were talking about, bringing it in, or I don't know what you said, but I implied that.
Well, so, I would say, to me, many of the same visions that I think other family members have of how can we create something other families didn't have to navigate, right? Or have to go through. So my vision is that Missouri has that we can make that happen. I have lots of different ideas and irons in the fire of little things to nudge it in that direction. And I think that what's important is that there's a lot of thought about where it lands so that it can be sustained in a way that doesn't change based on, how it can stay true to its intent. And I think that the other thing that's really important is it's not to duplicate anything out there, but to complement things. Because I think a lot of organizations, a number of your county boards are identifying and hiring family support navigators. This is not, if we can keep building up that workforce, this doesn't replace any of that, but it builds on that. And can it be a hub? And I was talking to them and they were like, oh, and I said, how do we build on what you're having, but also make that hub be something that even people that aren't on your staff are going through that same training and they're a part of it. There's a bigger network of that workforce, even if they're not the ones staffing the hub. Because that's what you want. You want hospitals to have people with that thinking and that can leverage that hub work website and those types of things. The other piece that's really crucial to this conversation is the conversation around options counseling. And that's what you're hearing at the federal level and what they're starting to define as a profession and a workforce. And options counseling are how, again, started with the aging conversation, right? How am I helping you understand your options for assisted living and, staying at home or whatever? But that the funding streams, whether you access them or not, get tangled up and impact your services and supports. And so, a parent getting a lawsuit, or a parent retiring and get a bunch of money, and how that can screw up the impacts when their child turns 18. My parents retiring when my dad turned 65 completely unraveled all of the things we had in place for my little brother, completely unraveled it. And we spent at least a year trying to figure out. All of a sudden he was getting Medicare, and it totally messed up his Medicaid and his Medicaid waiver. So there are things in our system that we know can unravel things for people. And I think that they do options counseling as part of that. And I think it's an important component in there that needs to be considered as well. But I'm interested, obviously it doesn't have to happen today. I can meet with a small group of you guys, share everything I've learned. We can sit down and we can call them. I can share some of the thoughts that might bring something like this to that.
Other thoughts?
Yeah, I like that idea, and I think simplicity is really important. I've been around long enough with DMH and in the DD world to see when things ebb and flow, and when recommendations are made. If there are recommendations, sometimes they don't get followed. Shelley's can attest to with the hard work you guys do at UMKC and try to work with us on. But I think simplicity, is important because it's a great way to get more buy-in. I think if we have a ton of recommendations that we have 10-page list of recommendations, that's going to be really hard, one, to implement, and two, to follow, and three, to get buy-in. So I think keeping it very simple is going to be really, really important, and having a venue to really facilitate that process would be very, very important, in my opinion.
This is discussion time.
Remember we talked about that meal getting heavy?
So all ideas are worthy and should be heard, so please share.
I'm thinking about what our report looks like. So, sorry. Thinking about what our report looks like in relation to Tim's comment about where we put in high-level recommendations and where do details, matter. I mean, we could put in a whole list of details. Tim, I think your caution is be careful there. But the details might be, included as examples, but recommendations at maybe a level above that, higher up. I heard Carrie, you mentioned, I think you mentioned that there's only so much you could have found out in state. Maybe that's a high level recommendation, which is somebody needs to really go through a careful accounting of resources at the state that are outside the scope of the time that we all might have on this. That there's a resource heavy activity that a starting point is, and that would be sort of a higher level role.
So let's talk for a minute about the idea of how a recommendation has a broad enough scope that it's not diagnosis specific. I think that's an important point, right? Ever since the autism insurance legislation was supported, I've had a survivor's guilt about all the people that were left behind because they don't have a diagnosis of autism. They don't receive those same services. And it was the best that could be done at that time. Other attempts have been made since. I think there's still active interest in seeing the access for services across less categorical diagnostic groups, which we would all support in a heartbeat, is something that has not gone away. But this is an opportunity for us as we structure this. And it touches something that's important to me anyway. So I favor that our recommendations are broad enough that individuals with various developmental challenges will be able to utilize the service. So that starts, getting back to an earlier comment today, that starts with what we call it. if you call it an autism clearinghouse, then that's gonna be an autism clearinghouse. So I'm just saying, I don't think we should do that. I think we make a recommendation which is broad. That will absolutely serve individuals and families with various developmental diagnoses, including autism. Right? I think that's probably something we all agree with, but it's something we have to keep in mind as we kind of go forward with the recommendation. I think that the document that you guys brought forward in terms of the failure risks can maybe, getting to Tim's point, you kind of list where all of these failure risks are in terms of access to care, diagnosis, lack of awareness, etc. And you say, you know what, guys, we can solve all of these. One thing. Turns out it's a big thing. But that kind of gets us to that idea where people's needs can be served within this space of whatever it gets called. And that makes really good sense to me. Because we do come back with a simple idea, big idea, maybe there may have to be discussion around it. And then we begin to break down into steps. So I'm curious about, Carrie, you said earlier that your thinking is that there would need to be a website. And so the thing that I don't think we want to do is create a census project, which we have a website and then it just lists stuff. So then the question is, what's going to live on that website? Where is it going to be? Who's going to maintain it? How is it going to be connected? And the resource allocation that will take to do that.
And so I would caution us not to get too far down the rabbit hole, because yes, we can make the recommendation and we can put some parameters and some description of what we mean by a website and what we don't mean by a website, but we don't have to have all of those answers for this, because I would hate for us to, in some ways, we kind of did that when we did the legislation. We're like, this is what the Autism Commission is going to work on, blah, blah, blah. And then we get in here and we're like, maybe we should have written this a little bit better. If we had gone through this process, we would have put in something much better. So I kind of want to keep that same thought process with our recommendations, where we are descriptive enough that we can communicate what we think we're envisioning, but not so descriptive that they think they're buying this 4-bedroom house and we really wanted a 5-bedroom house with an office downstairs that can be converted to another one. And then we get in trouble because we tried to build the second version instead of what we thought we were building the first time. So I don't think we have to get that descriptive of what exactly it looks like and what it houses. What I would envision from a website is sort of what they have in Minnesota. We can look at those examples. But for that sustainability piece, there are some things we're never going to change. We're never going to change that mental health has its website and it has its information. You're never going to change that DESE has its website. You're never going to change that social services and health and all these agencies that have all this stuff are there. But what we could put out is a different site that can be that door that can say, oh, you're coming in here and you're in this age group and you're at this stage of your life. Click here. Well, early childhood, first steps, and there's early childhood special education, and there's these things if you're not aware of, and whatever I'm coming from a state perspective. So of course there's a whole medical and a whole community perspective that could be incorporated in that, where it's not, you don't find everything out there. You find out there that First Steps exists and a way to get to First Steps so that you can find the phone number to call and go to First Steps. But you don't necessarily, First Steps is kind of an easy one to pick on. You could do a link straight to their application and send it through because they're pretty slick like that. But it doesn't have everything there. But behind that website, back to Shelley's point, there's actual people who you can call and you can talk to, and they know things and they can help you get beyond what you're seeing on that website. But that website at the same time can't have everything on it, because then you're just back to a state agency website that has 400 listings on this page and 200 on that page and 37 over here.
You are gonna have to build, for the staff though, the people who are fielding those calls and trying to deal with the range of issues. They are going to have they're gonna have to have a pretty broad range of access to information to cover the range of needs that are likely to be there. And again, they can be more categorical. It doesn't have to be every, I mean, there's a question about, can we make a list of every healthcare provider in the state who either is recognized or has said that they are confident in making a diagnosis of autism? That's a really slippery thing, you know, and that's just because that's just my little corner of the world, but that's a slippery thing to try to do. But people are going to be looking for diagnosis. So you have to have an answer to, okay, I've got a 4-year-old child and we think she may have autism. Where can I go? What can I do? And then there's a series of answers to that would be appropriate. So, and I can't think of all the questions that are going to be there, but they're going to be arranged. Some of them are going to circle on diagnostic services. Some of them are going to circle on other continuing care. And since we're focused on transition, we want to be sure that we are thoughtful about the sorts of issues that are going to be sensitive. I mean, we've had discussions around guardianship. And I mean, it's clear, I think, to all of us that the concept of guardianship is becoming much broader, is becoming much less patriarchal, shall I say. And so that's a whole changing issue. So we have to be thinking about, okay, who are those people? How are they going to get this information? So that information is going to have to be funneled in from various places, for sure. I mean, autism centers will have to provide certain information. Other healthcare providers will have to provide certain information, but you don't necessarily want to get into the specific referral. Oh, we think because you live in Columbia, you should go see Dr. Steinkoff. You know, we don't want to get caught up in that, right? And that would be true about anything. It would be true about supported living. That would be true about technological supports. That would be true about all of it. And then that gets a little bit tricky. So you want to have a place where information lives, good quality general information. You want that information maintained. You want people that are sensitive to that information, who have access to deeper levels of information behind that. And then you have to get the word out that that exists.
Yeah, to your point, it's about the process, not about the providers. So, you know, you were using the example of, I have a 4-year-old who I think has autism. What do I need to do? I would envision that person saying, well, do you have a primary care provider? You need to make an appointment and share your concerns and ask them, you know, do they do the assessments? Do they do this? Do they have a recommendation? So it's about the process for the parents, not the provider. And I think we would want to stick true to that as much as we can. And then obviously still be there to say, when the person says, but do they take Medicaid? Say, well, over here on social services, they have a directory of Medicaid providers. So you can go and look up by your county who takes Medicaid, so that we can direct them in those kinds of regards.
So we have to think about what those core questions are. So we haven't talked about employment. We haven't talked about living situations. We haven't talked about any of that. So information about all of that's got to live in this place as well.
Yeah, and
diagnosis is the easiest, but the rest of them are more complex.
And that's where we can, again, try not to go down the rabbit hole and think about what is our task for this stage. And this stage's task is to focus on transition to adulthood. So perhaps our recommendation is that we have this site with people behind it, and the specifics of that site would be that it could help parents address things, or help families address things regarding getting a diagnosis, regarding accessing services, regarding guardianship or supported decision-making, regarding the school IEP process, regarding employment, regarding housing, regarding health insurance and state benefits, that we want those kinds of things to be under there. And I totally agree. We want something that's not just autism specific, but the first request, the first recommendations can be about it addresses the most common things for transition. And then when we do our next phase, we're like, oh, remember that thing we recommended over here? It should also have access to early identification, and it should also have access. Now we need some people for this. So maybe the first time we want a really nice website that's designed really well and has those kinds of things we were talking about and has 10 people behind it to support it and help them in those things. And in our next phase, well, we probably need to add another 7 people over there because now they need to be also able to help with the early identification section. And then the next year we work on, well, they need another 7 people because we want them to be able to do access to care. So taking a bite of that apple.
So I think you wanna propose the strategy and not the sort of widgets to get there. And if you think about it, how Minnesota keeps describing it is, I think you keep with the word that it's a pathway hub, right? And that they kept using the spoke and hub concept. They are the hub of the many spokes. And the reason why it has continued to progress over 25 years is now all of a sudden employment's like, oh, VR, we want employment pathways. Okay, we'll partner now with VR and build those employment pathways and put these specific employment things in there to connect it to your spoke of employment resources. We're not going to maintain your stuff, but they're building pathways together. So as you develop each one of those pathways for lots of stuff, right? They're working right now with their department on housing or whatever it's called on a housing pathway. And so it's enabling them, they're adding the content areas as their partnerships are solidifying. So they're constantly adding the hubs and the pathways to that. And to that expertise, to that as well. So I think that, people who aren't sitting in this room or in this space are going to hear, oh, you want a website? Let's just get you a directory or whatever. Or, oh, don't you already have it on the government website? I think you also need to put the limitations of like those things quickly so that somebody doesn't see those as the quick fixes. Because this is actually filling a gap that does not exist. It does not exist currently. It doesn't really exist at a lot of places. And so there are good directories. The hub will point to those. We will leverage the Governor's Council. The other thing to know, and this is getting a little bit out of my wheelhouse, but I know just enough about it in the conversations I'm having around the No Wrong Door. The state right now is having a ton of conversations about interoperability. And those are related to the health data, right? And for the side of either using it for big data informatics or for billing and all these other things. But those same conversations they're having about how do we also make something forward facing as directories? Because if we already know from Medicaid's data and all these other organizations' data, all the providers in the state and all of these different people, why is someone building a new directory? It's already in there on the other side of the directories. So these big data conversations, the Tiger Institute and Cerner and all these other people that are talking about it for other reasons, I'm feeling like, again, for my layman's terms of this, is that I'm hearing it from like the billing side of it. I'm hearing it from like the research, bioinformatics side of it. But I'm also hearing it from a social care lens about one, how are we connecting all of these people together so someone isn't lost? But then I'm hearing it from the other lens of it being the resource directory or driving something that is allowing that. So some of the pieces you're bringing up are being discussed other places, but the hub doesn't have to solve that. That could be something that they tap into when it's there.
As far as the directory, especially on the Medicaid side, they have one. It's out there. It's on their website. It's clunky. It's only as good as a system. So if you put in autism provider, you're only going to get the ones who checked autism provider. You're not going to get, this general pediatrician is comfortable doing it and performs the assessments all the time and does the screenings all the time because they're listed as a general pediatrician, not as an autism provider. So that's some of the limitations, but some of that exists from that perspective already. It's just, it's clunky and you have to know it exists and you got to be able to Google the right way to find it. Whereas this hub, hopefully we know it exists and can direct people to what's already there.
But I sit here and I think that you've got the whole echo autism things and you have doctors that aren't going to be listed somewhere that are doing some of this stuff. But if your hub knows about those,
Yes.
they can make recommendations that say, don't forget the general pediatrician who might also X, Y, and Z, right? And that's that live person as opposed to a directory. So tap in, you might check this directory out, but then also think about these other types of people that you're not considering. Expand the capacity of what you guys are building in your infrastructure.
I was perusing that website as we're talking, and if you scroll down those sort of, contact a specialist, here's the phone number, very prominent.
Yeah.
And it speaks to your point on that, then the recommendation has to be properly resourced so that you actually have those people.
So if I mentally construct a hub, and I'm gonna have to look at the Minnesota hub, obviously. On transition, we probably picked the hardest thing. Right? Because transition is not one thing. And even transition to adulthood is not one thing, or even close to one thing. And so we're going to have within a transition to adulthood hub spokes for education, employment, healthcare, all of the sort of
Legal.
the domains that you referenced in your pathways work. So that'll be a bit of a challenge. But it at least makes sense. And I think if people in the room and on the call think that working now on the conceptualization of this idea, as we educate ourselves more about it, of a hub on transition to adulthood that has the appropriate spokes, and we begin to look at the type of information each of those spokes will need to have access to. That's in a lot of your lists already. So you've got a lot of that, the post-secondary ed programs, and we know about VR, but there's other opportunities there for employment, et cetera. I'm beginning to see how that could work.
And we don't have to have it all. I mean, if we can address the 5 big themes of transition, healthcare, education, employment, housing, legal. I came up with 5. I don't know if it really is 5, but if we are simply addressing that or acknowledging that they need to be addressed, we don't have to have everything that goes under housing in our recommendations. And certainly we never will, and it will hopefully continue to grow as that area gets better and evolves, and the same for all of the above. But again, back to the process, what do the parents need to be asking and how can they be directed to help them with those things? And I think we also need to be aware when we talk about, the information overload and the disjointed approach that we have here in Missouri and probably in lots of other places. And yes, we want to build off of things that exist, but we also need to think about how to pare down, because we have lots of little niches here and there and different things that just pull people in different directions and pull resources in different directions. And if we could consolidate them somewhat, so that it's easier for folks to use, it would be more effective.
So part of the reason why I called them was because they're using our intellectual property for free. And I said, I want to now steal it back from you. And so some of those hubs from a content pathway has started now changing it and adding some of the Missouri specific things. But so it's not as, and I don't know that you need in your report need to go down that far, but you know, some of the things that I started to look at, like they have a DB 101 calculator. Well, the DD Council funds a DB 101 calculator, but no one knows it's there, right? So put it on, get it, you know, the DD Council is our big partner. Let's put that together. So I think that your recommendation is more about, we want VR and DESI transition at the table to commit to building out the pathways, or to, you know, so how are you creating this recommendation, but then creating it so that the legislators or whoever are saying, yes, Belgrade has to be on the table, or so that people are figuring out, what are you leveraging so you're not duplicating? You might actually be taking something off their plate that they're having a hard time keeping a hold of themselves. So how is it solving issues in some of those big key areas you bring up already? There's a national training center on youth with developmental disabilities, was funded last year to National Family Voices and Got Transition and UMKC Life Course Center. We are charged with developing 6 pathways for youth transition, specifically for developmental disabilities. So there are things that you aren't starting from scratch. We don't have to solve all of that today. There's a ton of things to leverage. You know, your autism centers have a ton of great information. So it's just somebody who's, you know, organizing it. But I think that there's some building blocks that are there in existence. So I would be pushing the recommendations more about, these departments need to be at the table for that spoke or something.
What do you think about the probability of success in working with these other departments? Do you think there may be some variation, but do you think in general that would be viewed positively or negatively?
I think it would definitely be viewed positively. Collaboration between agencies, honestly, right now is for Missouri, an all-time high, which is a good thing. That has been a big push. That is a nice holdover from COVID, honestly, was some of the things that it forced the issue in some areas, in some places. The biggest issue or barrier that we will run into with collaboration, pulling some of these things together, is competing interests. Obviously, I won't say competing resources, but I'll say insufficient resources. I mean, the state is in a fantastic spot, better than it's been in a very long time as far as resources go. But we also have significant need in some areas, particularly when you're talking about some of these agencies that you're be pulling on. So, you know, health, yeah, they've got a lot of resources coming into them from the federal level. They are not state funded heavy for a lot of these things, and they are certainly COVID weary. So they had a lot of stress and strain and a lot of things put on their plate in that time frame. Social services, if anyone pays attention to things that are going on there, they certainly have lots of needs and lots of things that are going on too. So it's not that they won't want to participate by any means. Anywhere where we can make sense to be more efficient and more effective in all these little disparate things that are going on, but if we could pull them together over here, would actually make people's lives easier. Sometimes it's just hard to get folks to see that it actually is easier once we get it going. But there won't be any kind of opposition for collaboration for folks to come together and start putting this together. Each of these agencies have had this push of no wrong door for a long time. But it's just hard to get there.
Well, and so those are the conversations we're having with that No Wrong Door grant that I'm talking about right now. And so we're being very strategic in that there's a ton of money in the state, but it's the human resource side, right? And there's few staff to do a ton of work. And so Missouri basically is to the point right now of, can we tap on UMKC to do all the heavy lifting and pull us in as we need to guide the process on our behalf? And so, you know, that's exactly the conversation we had with the division of DD on Tuesday and Health and Senior Services later in the afternoon, and it was like, how is this building into your strategic goals? How is this helping you accomplish what you're already working on, and not adding more to some of your middle management, some of the other people that are being pulled a million different ways? Keep it at that strategic level. And that's where I'm seeing all of the leaders right now really are partnering at a really, really good partnership level. So I think that there's a window of opportunity, but it can't be put on them to solve the riddle or to help build it. They can influence it. That would be my recommendation.
Yeah, I just wanted to add to that also. You know, I like the idea of recommending the various divisions, or the various players, as the case may be, in the key stakeholders in addressing these things. But you know, I think part of our recommendations might also be, we've kind of touched on this a little bit, but you know, identify those areas that we have identified as, okay, these are the essential things that need to happen for, you know, when we think about adult transition, right? These are the key elements of that. We need to consider it from the medical, from all those things that Carrie just listed. And then we say so, and then we recommend that this group of people are the people who come together and sort of collaborate and develop a serviceable plan for families, individuals that they can follow from a practical standpoint. So I just wanted to add that piece.
But to be clear, we are asking for a new thing.
Yeah.
The new thing will be tied to existing things, right?
So the new thing needs people.
The recommendation will be for a new thing. I do think that's important, because otherwise, I think you, and as you point out, I think that there'll have to be some thought and energy around the concept of what this thing is. And then who are the spokes that are connected. But I think we have a lot of those details, actually. I hope we do.
Yeah, I'm glad you mentioned that, because I said that in the context of these are the key elements within this new thing that we're recommending that we need to focus on. Yeah.
John, I just have a question. I get nervous about, I think this is a great idea. I get nervous if we have something that may, like, we need something else in terms of like that face-to-face interaction. I get worried that, oh, they're, you know, I think, oh, we're gonna recommend this really nice website. People are gonna be able to access it. It's gonna have this, and this. We're gonna all, you know, come together, and then, you know, we're gonna have people that don't have internet access, you know, and don't even know, you know, still need that one-on-one interaction with somebody. And so I don't want us to think like that the website would be the end all be all. That can we still recommend things like a family support personnel or something? Like, we're still going to need people in the field that are going to be working with us that are going to know this information. They're going to know that the hub exists to be able to talk to you know, families and that kind of stuff.
I agree with that. And I think as we've discussed this, I think we pretty much all acknowledge that there have to be people who are there, and so there's a piece on the front which families, individuals, and we'll have to think very seriously about various ways. You commented that Minnesota is very intentional about the accessibility of that hub, and that will become an issue for us as well. But there's a way to connect to that hub. We know that there are parts of Missouri, although there's active investment going on, there's parts of Missouri where people don't have internet. And they tend to be people that are disadvantaged in other ways. And so that's an issue. But so thinking about that, so there's a front-facing hub that I would be thinking about tying to something, like the life course model for people to look at different stages of their individual's life or their own life. And then within that space, there are people who are there to hear the questions and to try to respond and to direct people. And then behind that staff, there are resources of information. So it's a layered process. Some of it faces forward, but it's a repository for people who know about stuff and some general information about transition, as I'm thinking. Then for the people that are there to know about stuff, there has to be training and support and education and informational resources. And that it will not be so easy, because those resources are shifting sands. And you don't know necessarily from one quarter to the next sometimes what's going to be there. And I would suspect even within the State Departments, there are changes in policies and processes and all of that. So I think that will be a bit of a challenge. And so there'll need to be strong commitment on that and good leadership within that group to make that work. But yeah, I don't think, I would not personally favor a website only model. I don't think that's likely to be anything other than what's already out there, and probably not as good as a lot of what's out there.
I think, but because I think you have to build a workforce infrastructure that's made up of different types of, I think what you're wanting to do in this recommendation is recommend that there is a need to be intentional about this is a real need, and get information and sort of problem solving and planning gets overlooked. Yeah, case managers do it, but they're formally doing it for formal case management purposes, right? And so we're not intentionally teaching people the skills on that whole fishing or vacation idea. And so what we're essentially trying to do is elevate everything. And so you might need a website that's maintained with staff that is doing that, but there is an incredible workforce out there that is underfunded, undertrained, that are community health workers, family navigators, information specialists, and all of these clinics and provider agencies. So a recommendation could be about how you build capacity in there. Do you recommend a training certificate program? Do you recommend something that becomes just not that different than the DSP crisis, right? And if we see this as this invest in these people who will change the trajectory of people's lives, it goes back to Seth, what you brought up earlier, is if you would invest in these positions to get in front of crisis is what you're trying to do. You're trying to prevent crisis in the individual's lives at different stages of their lives. But you got to make a real investment in that workforce, whether they work for the hub or not. You're trying to create that, so are their positions funded? How are they paid for? And those are some of the things that I'm particularly interested in helping the state figure out, because there is that workforce there. Hospitals have parent centers there. So how can you help them have the same messaging? How do you help them know about the resources they can tap to if the hub was built? But then there's a third layer that you also need to be mindful of. So the division of DD, right? They can dictate what the service coordinators are trained on. Their person-centered plan is now aligned with the life course framework. And so they're all the state employees are trained to use the life course tools. They don't have that mandated at a county board level, but that's another layer that families might come in and interface with, right? And then you started talking about transition coordinators. So you could talk about your recommendation being about building the people that are problem solving and planning and stuff, their capacity somehow. Like how can you, because that's who they're going to be talking to too.
Shelley, your comments were going, I think, where my mind is going, not precisely. Some of my thoughts are a little muddled, perhaps, but if our recommendation is
for this sort of hub website. That costs money. That's a resource. We're going to be asking at some point, it's going to be a recommendation to the legislature to spend some money on something that we think is strategically useful and impactful. And at the end of each of those spokes are coordinators, perhaps. They need funding. But another layer, in a way that I think is different than you were talking about, is they're actually people providing services that are teaching people, supporting people, providing interventions or training programs, et cetera. And so where might we want to take an opportunity to recommend, here's another set of places where we can spend some money to make people's lives better for programs that we think maybe exist now but are underfunded or don't exist now that we can invest in. This is our chance to do that. I don't know exactly where our priorities be on that, but that seems to be in addition to the hub, something we have an opportunity to think about.
Well, and it's been discussed here many times, the workforce challenges in the whole field of developmental disabilities, special education, healthcare providers, I mean, everywhere. So it makes sense to try to connect with people who exist and to try to support those people in the various ways that they may need in terms of with training or validation or whatever they might offer, makes better sense, because you can have a core operating staff, but a part of your overall operation. And my thinking about that, you guys are both involved in full-time education and training and research entities, but my sense is that to do that, you have to partner with somebody who does that. I think you have to partner with people who know how to teach this stuff. And that becomes a partnership with the university or with some existing entity. Again, we're not going to duplicate the wheel here. We're going to say, hey, there are people that know how to do this. Yes, there's a grant, or that you have to support that effort, time, people. But that's, I mean, the days of medical education where, it was, what was it? Watch one, do one, teach one. Literally when we're doing procedures, and that's about the way it was. Oh, is that how you think on it? And yeah, you're going to do the next one. Poor people, right? But anyway, so I don't think we can't trivialize that process. That educational process is an important step. So I'm glad you brought that up, because I think that is important. And I think it's a workforce expander as opposed to a workforce competitor. So that makes good sense.
I think to your point about the people, Dale mentioned earlier, and I think we've heard this from other folks just throughout this whole process, that one person gave them the information they needed. And so when you were talking about the layers, those are the, I guess when I was thinking about, and I don't know if this was what the group had in mind or not, but when I think about the hub, I think about it being a resource not only for people who actually need to use these services, but for the people who are helping the people who need to use the services and the individuals, because we know that people don't know the question. Sometimes they don't know the question they have. They may be looking for something on the hub, and someone at the Senate Bill 40 board may be able to say, well, that's not really where you want to go. This is where you want to go, because the person doesn't even realize the question they have. So I think that's a great point about the people and those layers of people who are going to interact with this type of resource.
So on that website, if you click the professional up on the right-hand corner, the website totally changes to that target audience, Carrie, that you're talking about.
Okay.
So it's like, how do you now help that person navigate that thing? And so there is a training component on that. So they are trying to train those types of people as well. So I think that's why you want to be careful that you're not presenting a website, but you're presenting a capacity building infrastructure as your recommendation, with a website that is sort of almost your guidebook. It's the screen. Right.
And, you know, because one of the things that in conversations around the country that I've been having is, as we look to fund peer support services or peer navigation supports, you know, Missouri has it built into the Partnership for Hope waiver, but it's an underutilized service because one, people don't want to take away from their kid potentially getting a direct service. They're worried about that on their budgets. But I always worry that you create a resource that you can only access if you're eligible in that program, right? And so this has to be outside of any one thing. You don't have to become eligible in order to access the navigation or the support. And so often in our field, that's the case, right? So it's like, well, once you get a service coordinator, they might help you navigate, but you might not actually get to the service coordinator. And so there has to be stuff, I always say, outside of the front doors, that needs to be an investment by the doors that actually makes it easier when the people come to your door. And there has to be that recognition that it has to be, you know, if I go, and we run into this with guardianship, right? Parents don't know where to go, so who do they call? They call an attorney. You think an attorney is going to tell you to do supported decision making? No, they're going to tell you how they can help them get a guardian, right? So if you're going to truly have an informed decision making infrastructure here, it's got to be outside of the infrastructure for which someone's going to give you their funds.
And so that's an important part. I mean, it's obvious, but it's really important to state. You don't, you know, if you have, I don't love your metaphor outside the front door because people just need to go through the right door. So why waste time going for the wrong one? So it's a very nice metaphor.
I think in terms of best practices, I'm just trying to like wrap my head around like what we've been working on and people is, so there are definitely best practices that have been implemented at state levels that the state is fully on board with at different states. I like the idea of having, you know, recommending, you know, we have this best practice of a comprehensive transition program or, you know, an employment internship in high school, et cetera, et cetera. These are the outcomes that VR has that is demonstrating these are fantastic and that we should put more money towards, you know, employment training or dedicate more pre-eds money or whatever we can do. Because I don't know what I'm trying to say. I think I'm trying to like solve too many problems at one time.
Lots of solve.
What?
There's a lot to solve right now.
No, I do know. I mean, I'm on another state board, the special education advisory panel, and we've had this conversation the past couple times about the training of special educators. So while we might say, I mean, I worked in the schools. I know we're at capacity. I know people aren't, you know, aware of certain things, but I know that it is now on our radar at a state level to perhaps look at the requirements to be a special educator in the state of Missouri. Because it's very low to be qualified. And so we can't necessarily then expect special educators to know in middle school or in high school that they're even supposed to do any of this stuff. When I just read a paper about talking to a special educator and she didn't know about certain things that have been around for quite some time. So that also goes back to us as teacher prep programs, like that we are going to start to have to try to prepare our special educators. I'm just talking about the education world better. And I think if we maybe have some sort of voice or some recommendation that says like, oh, hey, we really need transition specialists. They really need to get certain training. They, you know, to look at post-secondary ed employment, independent living. I think if it comes from a recommendation point from a state commission, I think that other state programs will fall in line. Like then our special ed advisory panel will say, oh my gosh, okay, now they're recommending this. We're gonna recommend this. And then I think if like we can, help the legislature or help, fund certain things to promote like, oh, all these people are coming together and they're saying this. We need to actually support it. Does that, I don't know. I'm just trying to, this thing is so big.
Yeah, it does.
I'm just like.
Lindsay, it does raise a question, and maybe it goes back to the point I was maybe not articulating as well earlier. Just taking education, just one example, and there could be other things that, there are other things that would be important. And I'm still a newbie to Missouri, but my understanding is, as an example, I think we're vying for last place in starting salaries for teachers, 48th, 49th, or something like that. And if we think that transition to adulthood starts, earlier in middle school or before, special educators are the one part of the critical part of the delivery system of that care. Can't pay people enough, we're not going to have that resource. That's paying people more is, I would argue, capacity building. Mm-hmm. Is that, would we think that that's within our mission to make that kind of recommendation, which, by the way, rises all boats as well. And that's not instead of the hub, which is critical as well. But that's an example, I think, of something I was thinking about. Where do we, on the other side of this are going to be legislators. They're used to people making recommendations. For them to spend some money, can we have, take an opportunity to make a strong recommendation to spend money in places that we could, again, really impact our communities?
Well, I think we can, with the approval of the commission, we can recommend anything we want to recommend as far as I'm concerned. And if there's a consensus, I'm always a little wary for
That's why I bring it up. I want to do
yeah, no, only at the practical level, because Missouri also lags behind in terms of Medicaid payments for physicians, and we have trouble in many communities getting access to medical care to people that have public insurance. So if you sit in my chair, if instead of being 40, whatever we are in Medicaid reimbursement, we move that up, would more physicians begin to take Medicaid? I don't know, but it's a logical conclusion. So kind of thinking that through, my guess is there's opportunities at every step here for more training, for more investment, etc. So I think that those things should absolutely be on the table, and I don't oppose them. And if folks really feel like we should have a recommendation, I kind of like this failure model where we say these are places where there is failure now, so we know there are failures in many primary care medical practices in terms of informing people about transition in an appropriate time frame. We know that there are challenges within the schools. We know that there are challenges on the part of probably everybody who touches these kids and families. We also know that in each of those spaces, there are champions who have done amazing work with families and individuals. So we can't tar people with a brush necessarily. But I think to say that if we come to a conclusion that there are fewer Medicaid accepting physicians than would be optimal, I don't think it's a mistake to necessarily call that out. But I am not personally convinced that a commission's recommendation to increase salaries for teachers and payments for physicians and so forth is likely to get much traction, but that may just be my own skepticism. So I'm not arguing against it.
I'm not actually arguing for or against it. I'm agnostic about whether or not that's the right thing for us. I just wanted to bring it up so we discuss it, because I think part of what you're saying too is, or the implication of part of it saying, I think, is that there are a million things we could argue that people spend more money on. And if we throw so many things at, then that's a losing proposition in terms of, that'll dilute a message as well. So, yeah, I don't know what the right way to go on that is, but.
Well, and what if, going back to, how we want these different positions and different things to be funded, are people gonna come back and say, well, why can't you just fund me? Like, why don't we just use, like Shelley said, the current workforce, suggest, this is part of our, what we require as a Missouri caseworker, X, Y, and Z, but then invest in the current workforce instead of adding on. Cause I don't know, do they get upset when you suggest new people when we've got people to do it, or do we just not have it?
I see it as a different function.
Okay.
So if you have a family navigator or a case manager at a targeted case management system or at a hospital, yes, they're providing assistance and help to the families, and sometimes it crosses outside of their system. But a targeted case management system navigator, primarily working with DMH services, may not have enough information to talk to and help someone access something over here, Department of Health.
Got it.
I mean, they might, because they do close together, so this other level above that would still leverage and access those existing people, but this level up here would be designed and trained and plugged in so that someone, if we said, hey, 10 people appear to be the people behind this screen, can go across all of them and point you in the right direction, and plug you back into the targeted case management person over here if you didn't know they were there.
Versus just educating this one and this one on the same things. Having somebody new would be more beneficial than.
I think so. If you have someone working in a hospital system, they are, no offense to anyone in the hospital system, they are loyal to their hospital system and what their hospital system wants them to do and what they need, what they can be knowledgeable about, or and yes, it would be great if someone, pick a system, Children's Mercy popped in my head, no, don't know why. But so if they're in Children's Mercy, they may know a whole lot about how to plug them in with resources within Children's Mercy and maybe in that little area, but they might not know nearly enough about navigating the Department of Social Services and know that this program for special health care needs is over at Health and Senior Services, not mental health, not DSS. And so this level up here would absolutely tap into that navigator at the hospital system, provide maybe training opportunities throughout the course of the year for people from all around at those levels to come up and learn a little bit more. So bringing up their knowledge and being able to bring up the person who comes behind them to bring up their knowledge. And that level doesn't exist right now. It just doesn't.
I also think this is a really important point, your point and Lindsay's point, because, if we flip it around a little bit and look at it from the perspective of people who are seeking services in the context of the failure risks, you'll see some of the failure risks that are listed here are just looking at one, lack of providers or provider capacity, including geographic concerns, transportation, and, from the perspective of the consumers, what good is it to have somebody to communicate with who can say you need this and you're eligible for this service if there's not enough providers available in different geographic regions and across the state? I mean, we know we get calls on a regular basis. We were recommended by our pediatrician to get an autism evaluation. We can't find anyone. Everyone we call, we have a 1 year, 2 year wait, and that problem is compounded as a person gets older. There's less providers than even if the child is identified at an early age for a diagnostic evaluation. So I do agree that I think somewhere it is within our scope. It has to be, I think, to recommend special attention be paid to improve the capacity of providers, the infrastructure of people who work with the autism and TD population. I just don't want us to overlook that.
Agreed. So there's certainly no limit on the recommendations that can come out of this committee. And I can speak a little bit. I participated in a project spearheaded by Health and Senior Services, and it was to address the workforce on the healthcare side and the public health side of the workforce crisis. And so one of my recommendations or things that I would share with this group was those recommendations when they put forward a report. I don't know that it's been made public at this point or not, but it ran the gamut for what those recommendations were. They said we need to fund X, Y, and Z. They said we need to increase pipelines for providers through, this process, that process, and this process. There were recommendations for changes to legislation or statute. There was recommendations for policy changes within department. And I would recommend that we approach it from that standpoint, because there has been historically, backlash is too strong of a word, but not well received when the only thing that we come forward with is a list of money. Because money won't solve all the problems. It can help. And certainly there are places where we could definitely put resources to good use, but changes to policy and changes to statute or legislation or specific recommendations for pilots. And we have some of those that we've listed on here, some things about, how can we get a joint assessment process between schools and medical providers for that autism diagnosis or whatever the diagnosis may be that comes out of that joint process. And that was something that, we brought up in our group, and they're currently doing. I think Dr. Nadler talked about that on the Kansas side. There are some school districts that are partnering with some medical providers to do that joint assessment so that families, back to that situation we'd identified a possible barrier. Well, family had the kid identified in school and they went through the IEP process and they thought they were good. They had a diagnosis of autism in the educational setting, which didn't get them anywhere a few years later. So I think our recommendations should be comprehensive from that perspective and include multiple different things other than just funding, but absolutely funding can be.
Yeah, I agree with that. I think that if you have process improvement offers, or and sometimes you just simply say we just don't have enough providers, and there are a range of reasons why we don't have enough providers. There are fewer people doing primary care. I mean, there's all sorts of stuff that it's never just money, but it always includes money.
I guess that's why I asked that question. Oh, I'm sorry.
Sai, you have something to say?
Turning on my camera got all this attention. I appreciate it. Can you hear me okay?
We can.
Yes.
Okay. I first I'll just say I appreciate the entire day's worth of discussion that I've gotten to listen into. A minute ago we were talking about, should we create new people to do this, or should we use the existing workforce? And I don't think anyone would disagree that we don't have enough people in the current system to do case management for all of the individuals who might need it. But so to that point, and I think the conversation about, well, if our recommendations are only, fund these 50 recommendations, increase reimbursement, I think we should still recommend what we think will help. But part of that could also be changing, who does that work. And so if we can recommend a policy or a sort of a structural change so that new people are eligible to be employed as those navigators, and can bill for, bill the existing codes at the existing rate. I'd love it to be triple, but if we just take where we are, but more people can bill it, then more people will bill it. I think there have been examples of that in other areas, even in Missouri, where I think it's in weight management, where they created a billing code for, family behavioral health counseling or something like that, and nurses can bill it and it's reimbursable. Again, it doesn't create new people to do the work, but it expands the number of people who are incentivized to do it. So I think we can do it on all sides.
Thanks. So we need to wrap it up and come away with some specific to-dos, I would think. So I think what I'd like to do personally is just have the chance to work with the groups, continue to work with you and Jeannie and the people in Lindsay's subcommittee group to kind of distill and look at some of these recommendations and kind of decide. I do personally like this kind of failure model, and when, because of the failure, here are the process improvements that we recommend. I think we have a consensus about where these failures are. I think that we will arrive at, I don't want to use the term of laundry list, but we will arrive at a bullet list of suggestions and recommendations that include attempts to support workforce expansion and so forth and so on, to distribute healthcare in ways that are more equitable, and nobody's going to argue with any of that. Though everybody sort of already knows that's there, but we're at least planting our flag that we are aware of and consider these significant issues. Then I think to come back to the hub concept, I think we're going to need to flesh that out a bit. And I'm happy to work with anybody that wants to work on that. Can I pick your brain?
Absolutely.
I think that spend some time reviewing the Minnesota site, looking at the strengths that are there, and then thinking about a different scale of that for us, clearly. And then come back with some sort of a description and of the recommendation and what we think that might take. I think, Carrie, I need your help, I think, with that in terms of the other agencies, for sure, that to the point made earlier, that we would want to have in the room and around the table to begin discussing that concept. So I think preparing a report, I'm anxious to have something which is brief, informative, clear, and makes its case well. So that'll take a little bit of work, but I think we can work through that. And we can do a lot of that, I think, via email or Zoom calls or other ways. I don't think we need to get back together necessarily to do that. I would opine that everybody who is on the commission should have the opportunity to contribute to that. And so I think what we'll do is circulate rough draft, give people an opportunity to react so that everybody's included in that process. And we technically have a few extra months going into next year. It's just that we're then going to be already working on the next phase of the commission responsibilities. So hopefully within the next 2 to 3 months, we can get a lot of this work done. So that everybody, and if anybody either on the phone or on the Zoom or in the room wants to specifically work with us, just reach out to me. I'm happy to include anybody that wants to do it. And I think the discussion that we had today, the contributions today, the presentations that we had today really moved this conversation along. So thanks to you guys for helping us through this process and all the thoughtful work that's going on in the background that will now give us some directions in terms of some of our recommendations. Other thoughts? Okay.
Are we still we're missing people, right? Like,
Oh.
not missing people, but.
No, I'm glad you brought that up. Yeah, we have 4 vacancies.
Yes.
Yes. Yeah, thank you for mentioning that.
I think we have some suggestions, but people saw to communicate those, which don't.
I've seen a few suggestions of individuals, autistic individuals. Don't know if I've seen the others though.
So we currently have 2 openings or vacancies for special education providers. We have 1 opening for an ABA provider and 1 opening for an autistic individual. So, okay. On the commission.
And we have had 3 or 4 names sent to Kristen and I of autistic individuals, but I don't think, do we have anything else? Any educators? Do you have an educator?
No, we're still, Mark Wheatley is getting
Okay.
some recommendations on that end. And then I do have 1 ABA provider that's been recommended.
Okay, okay, but don't hold back. I mean, if you know somebody that you think, and it'll probably be similar amount of work next year as of this year. Groups and people will be working together, and so I know it takes time, and everybody's had at least 3 other jobs, and it's difficult. So thanks for the work that's going on. I really think it's been gratifying, and I said at the beginning that this was probably the area that will be considered that I knew the least about starting out, and I feel like I've had a lot of education, and then I appreciate everybody's efforts to bring me up to speed.
Do they have to have certain requirements for the people who are coming on board? Like, do you want higher ups? What does matter?
I want somebody that wants to be here and wants to work.
Got it. I have ABA providers, but they're not at higher ed, or they're not,
We'd like to have somebody that who probably has, some seasoning, some perspective is useful.
Yes, certainly. Got it.
Yeah, and then in regards to that, so send all the names forward, but also if it's not readily apparent what part of the state they're from.
Got it.
Not that we're intentionally trying, but
No,
when we
yeah.
first put the group together,
It's a
we
good
tried to make sure we were capturing across all those different categories, that we didn't have, everybody was from St. Louis or everybody was from Kansas City. We wanted to make sure we were capturing all regions of the state. And as people come in and out, we don't want to accidentally wind up that everybody's from Southeast Missouri kind of thing. So we can just kind of watch that. It doesn't mean that we won't take a person's name because someone is already from there. We just don't want to get heavy in one spot.
No, totally.
I do think because of the way it came about last year, I think one extra step might be helpful, which is that at least Kristen and I will probably talk to people and let them know what it is they're signing up for. Because I've done this before, but most of you haven't, and so I had a general idea of what it was going to be like. And I want everybody to have a clear idea of what it is that they're agreeing to do. And I hope all of you will continue in your current roles, because I think we've learned a lot from each other, and just hearing from each other and just in different perspectives is really helpful. And so I'd like to be able to hold on to the talent that we have. Okay, anything else? Thanks to those of you who hung with us all day. Appreciate your being there, your listening, and your participation. So thank you very much.
Thank you.
Appreciate all of you guys for making the effort of being here and contributions today. And you got 15 minutes.
Thank you, Jones.
Thank you.
You guys, I really appreciate what you're doing. It's just amazing. It's hard work, and